Good evening, blimey. Good evening, everybody. Welcome to tonight's Health and Adult Social Services Standing Scrutiny Panel meeting. Remind me to see if we can change that title at some point, because it's a real mouthful. I'm Councillor Daniel Crawford, and I'll be chairing this meeting. We are in the council chamber this evening, and it is a public meeting. We are also hybrid to allow colleagues to join online, particularly our NHS colleagues who can't be with us in person, and we very much welcome their contributions this evening. I do need to tell you that it is live at present, I hope, in glorious Technicolor. It'll be recorded, and it is currently being broadcast on Ealing Council's YouTube channel. And I'd ask members and participants to be aware of that fact. The agenda papers should be in front of you as well as online. Right, I need to do some formalities, which are apologies for absence, Anna-Marie, from Councillor Alexander, who had told me she was going to be online, but I don't think she is online. I think she's apologising. So can we take that? One of our co-optees, Daniel Norman, is online. I can see his name up there. He's attending online. I'm not aware of any other apologies for absence this evening. Councillor Mutaza is attending online. Councillor Mutaza, good to see you. But everyone else should be in person. I do need to introduce one of our new co-optees. Mr. John Chesters is here from Ealing Community Network. Welcome, John, to your first meeting. Would you like to introduce yourself and say a bit about Ealing Community Network and Ealing Community Transport as well?
So I think most people probably know ECT, because Anna was here for many, many years, but ECT has been going for, well, over 30 years. And I took over from her about 18 months ago. So I'm now running all the transport in the area. ECT got the depot in Greenford. We also run services in Cheshire and also down in Blandford Forum. So we cover Dorset too. And yes, as Daniel says, also part of Ealing Community Network. So on the board of ECN. Okay. And if anybody wishes to come and see us at Greenford, you're more than welcome. We do lots of work in the borough. We want to do more. Okay.
So I would endorse that message from John. All councillors should have had a communication from ECT subsequent to your election in May, or in some cases your re-election, to go and visit ECT's hub in Greenford. That might be their base within the borough, but they travel across the borough and well across the borough boundary on many occasions. They're doing excellent work. It'd be useful for colleagues to view that for themselves. And, you know, it has been long my ambition and the ambition of John's predecessors to ensure that we have a full presentation of ECT's work to this panel, and God willing, we will make it happen before my time is up. So, John, you're very welcome. Please chip in as and when you wish to. I do need to say something. There are no urgent matters, but I do need to say we've got three substantive items this evening, and we will have at least 3 substantive items for the remainder of our meetings. We've lost a meeting due to the sad passing of Her Majesty Queen Elizabeth II. We're not going to get that meeting back. So in the work programme in a minute, I'll talk to you about how we're going to get through all the business. I'm going to shut up now, because otherwise I'll talk for too long and invalidate the message that I'm trying to espouse for brevity from everybody else. So there are no urgent matters. I do need to ask people for declarations of interest at this point. So can I start with councillors? Anybody with a declaration of interest?
I have to declare interest that I am a local provider GP, and also specifically for item 8, I will either leave the room or I will keep silent.
Thank you, Councillor Mataza. There's no need for you to leave the room. I think you can view the proceedings, but yeah, if we can keep your comments to a minimum during that item, that'd be great. But please take a full part in the rest of the meeting. Anyone else with a declaration of interest? Councillor Conti. Yeah, sorry.
Yes, so I'm a GP. I don't work in the borough, but I work in North West London.
Reflected in your in your declaration of interests that you submit to the council. Councillor Wesson?
Again, I don't work in the borough, but I do work for the Nursing and Midwifery Council, which is declared in my interests.
Yeah, everyone's very good at declaring their interest. I'm going to ask anyone else, anyone who, Alan, is there anything you need? There's nothing you need to declare that isn't standard that you've always done. So I'm going to move on. There are no matters to be considered in private. I'm going to check with my NHS colleagues. All of the matters that are within the papers are all in the public domain, and therefore we can freely discuss all of those matters. But we may need to be careful in some of our questioning and respect that, because some of these proposals are still in train rather than being fully fledged. Right, I'm going to do something radical and take the work programme before the minutes, and hopefully that's not going to cause me too much difficulty. The reason for doing this is to, as I said to colleagues, we've lost a meeting and therefore we've had to consolidate our remaining 2 meetings. So Councillor Steve and I are going to thrash out what those last 2 meetings look like, but it should be something like what is contained within the work programme. Any councillors you have thoughts on how we might proceed, or co-optees indeed, are welcome to fire us your thoughts. I want to make sure that we cover all of those items and give them the attention they deserve. Now, this is the part where I need to ask you and all of us to do a little bit more in the spirit of these times. So I do need to speak of those February and April meetings. We have, Councillor Steed and I had a very successful visit to Ealing Hospital since the last time we convened this panel. I've been biased, but I thought it went very well. We might hear from Simon and colleagues to the contrary shortly. But it was great to be back for the first time for both of us, I think, at Ealing Hospital since the pandemic, seeing the progress that Ealing Hospital has made and the dedication of the staff, that we would like to re-emphasise this evening. Our immense gratitude to everyone within the NHS for the outstanding care and attention they provide for Ealing's residents. We do, in light of losing some meeting time, I'm looking at Kerry, we do have some plans to go visit some other places, including the wilds of Essex, Hounslow, and various other places, to talk about different elements of social services. And that is the way we're going to carry out some investigation on social services, particularly relating to learning disabilities, education, employment, and direct payments from leaders in the field, so that we can take some learning. We don't have dates for all of that or any of those visits yet, Kerry. I don't think. You're going to come in and tell me I'm wrong now. But we will get them, and it's my intention to share those with the panel, fully in the knowledge that you might not all be able to attend, but some of us will be able to go, and that will inform some of our work. Kerry, go on.
Sorry, just to say that we've been liaising with the DAS in Hounslow, returns from leave at next week, and we'll be confirming a date for us to visit, hopefully before Christmas.
Yeah, that'd be brilliant. And, you know, I'm hoping we will run right up until April with this panel. So we have all of that time to go and visit things that people want to see. And that could include a visit to ECT, if we want to do that. And that could include a visit to any NHS services that we'd be allowed to visit. And that'd be great. The last thing I want to say is, there has been immense public interest in this meeting and in some of the items for this meeting. I'm very committed to trying to hear the views of the public and give them ability to ask questions, as I think we've shown in the way we've done it. It's going to be very difficult to get public participation on each of these items, but I have agreed that Eve will be able to ask at least 1, possibly 2 questions on the mental health item, certainly, and we will try and facilitate that by the end of this meeting. What I would say is, any questions that are not asked, we will make, both on mental health and on all of the items, we will make sure that we document those and get written answers well in advance of the next meeting, as we've always as we've always done. And with that, Anne-Marie, I think we've covered the ground that we needed to cover. Are you going to tell me I've missed something out now? They're the minutes of the last meeting. That is quite important. Yeah. So I do need to ask you under item 5 to look at the minutes of the meeting held on the 29th of June and to confirm, those of you that can remember that far back, that they're a true and correct record of that meeting. Because if they're not, we're in trouble. I need someone to say, yes, they are, please. Thank you, Councillor Conti. Brilliant. Okay, I'm going to take those as agreed. We have had some additional items arising from that meeting. So we've provided some documentation within the agenda to do with our responses and information from the Care Quality Commission. Now, we've had some difficulty to invite the Care Quality Commission to a meeting. We're going to pursue how best to follow that dialogue. And there was a request and recommendation to the Local Development Advisory Committee around planning air pollution that resulted from some questions from Councillor Wesson. We're going to make sure that flows through just as soon as LDAC has restarted its work. But I've had a conversation with Councillor Brett. She's very happy to take that on board, and with the draft local plan being published this evening, I think we can fit all of that in. So now I think I've accomplished all the housekeeping, which is great, and we're already behind on time, so fantastic start. We're going to move to item 6. I'm going to try and take them in the order that's indicated on the agenda. Sorry, Nahar. So the first item is an update on Ealing Hospital. I'm delighted that Simon Crawford, the Deputy CEO, is with us in the room. We've also got Mark Titcombe, the Managing Director of the Elective Orthopaedic Centre, is online and ready to participate as well. You're going to both provide the panel with a presentation on Ealing Hospital. It's similar to what's in the agenda pack, so people should be familiar with the information, and then take questions on future plans and general questions. Indeed, we've got it brilliantly right there in front of us. So Simon, would you like to start? And then
Yep, happy to kick off. So thank you very much for inviting us to the committee today. As Councillor Crawford has indicated, he and Councillor Steed visited Ealing Hospital early in September, and a very positive visit. And I think what came out of that was a recognition that in response to COVID, there'd been quite a number of changes on the Ealing site in response to COVID. But equally, a lot of those were temporary changes that we had then sort of coming out of COVID, put things back in place. But also there were a number of things that we had invested in terms of new services and refurbishment of services on the Ealing site. So the presentation really is to give a chronological sort of overview of some of those temporary changes that took place and the investments that have taken place since. So there's two elements to the presentation. There's those things we did in response to COVID and the investments that we made up to this point in time. And then Mark, as you've alluded to, we'll talk then about the community diagnostic centre that we're planning to invest on that site, and it is progressing at this point in time. So so I think most of what's on that slide I've probably said. So yeah, next slide then, please, Mark. Yeah, in response to COVID, like the rest of the NHS, it presented significant challenges as an acute hospital. We had patients coming in with COVID. We also still needed to treat patients who didn't have COVID. So we separated wards and departments to try and protect patients in terms of those who had COVID and not non-COVID on the site. So a sea change in the way we operated. Staff rose to that challenge, and I won't rehash everything you probably already know about COVID, about infection control processes, masks, the changes around visiting arrangements, and those kind of things. At the same time, we did then then go on to, in August, opened the same day emergency care and outpatient facilities with dedicated parking and access on the Ealing site, and also sort of improved our adult acute care support for frailty patients, was strengthened, recognizing that, you know, certainly during COVID, the challenges that older client group was facing, and the dedicated service that we could put in place to support them. We upgraded our mortuary facilities and viewing room in terms of, obviously, there are increased numbers of deaths during the COVID time, difficult time for relatives who lost patients in short order. So making sure that we were as sensitive as we possibly could in terms of supporting them through those difficult times. We had to segregate our theatres into emergency versus planned cares, again, for the rigorous infection control issues. You know, initially, the early days of the response, we stopped all the elective activity, but, you know, people waited long times for operations that they still required. So late summer, early autumn, we began to make sure that we could bring elective activity back through the hospital, but we had to have really strong segregated theatre recovery areas, as well as separated wards and infection controlled areas. So we created a dedicated green planned ward care area with 20 beds to enable us to undertake the elective activity on the site. And we also upgraded our monitoring and our critical care equipment and facilities in the ITU, in the A&E department, and in 6 South, which is a ward where people having had their elective procedures go for recovery. So enhancing all the technology in terms of the monitoring of those patients after surgery. And then in the November, we created a dedicated paediatric outpatient day case area, and that's very sort of child friendly and young adult sensitive area. It's away from the main hub of the site, and it's a calmer environment for parents bringing their children into the hospital. We upgraded our gynecology, daycare and outpatient facilities, and we created dedicated maternity and ultrasound scanning facilities within the site. And then in December, we upgraded our oxygen mains to the respiratory ward, because, again, in terms of response to COVID, demand for patients needing to be on oxygen, and we needed to strengthen the resilience of those systems and increase the capacity on the site. And then alongside that, in areas like recovery and in theatres recovery, and in some of the ward areas, putting in sliding doors to several ward bays, so that better observation of the patients and quicker response to those who are in crisis as a consequence. Moving on then, so a lot of that was all about responding to COVID, improving the response to COVID, improving the resilience to highly unwell patients with high levels of acuity, high levels of dependency coming into the hospital, and being able to care for them in a sensitive way, but also making sure that we had the right equipment and the right technology to support them. So then from April 21, we installed 3 community MRI scanners on the back of the Ealing Hospital site. Those are run by Imperial currently as part of the community diagnostic support. We started refurbishment of our ITU and HDU facilities, because, again, what COVID taught us is that we didn't really have enough ITU facilities on the Ealing site, and we didn't have the flexibility of swapping between level 3, the highest level of critical care dependency, and high dependency. So we expanded the capacity in the ITU facility to be able to care for those on high dependency as well, and flex those beds. So it's now a 12-bedded unit. It was 9 previously, but there's more flexibility in terms of those being for the higher levels of dependency and the lower lower dependency. We installed a covered walkway outside the ED to support social distancing at the time. And then in July, we finished that expansion of ITU, HDU, as described above. December 20, then we restarted our out-of-hours emergency general surgery on the site, because in response to COVID, we'd taken that down because of staffing issues, predominantly, in the sense that we needed those staff to staff the high dependency and critical care units, so we weren't able to run those trauma and emergency general surgery lists, but we started those again back in December 21. We created an additional 4 bays of 4-bedded recovery unit for patients after going through theatres, and that's in line with us increasing our elective activity and the targets to catch up on the backlog of elective procedures. And with their LAS, we trialled redirecting patients from UB5 and UB6 postcodes to Ealing Hospital up to 7 a day, to release some of the pressure on Northwick Park, but also recognising that a number those catchment areas link with the social services sort of catchment area of Ealing Borough, and therefore aids discharge planning for those patients as well. And then in the current sort of financial year, since March, we restarted our trauma service. We completed the upgrade of our endoscopy suite. We're waiting that to be JAG accredited now. So as a result of the refurbishment, we should get that. That's the body that sort of assesses endoscopy units and gives them a kite mark sort of standard, but they've got a backlog of doing those assessments. But we're hoping that will be done early in the new year. We began refurbishment of our cardiac cath lab. That was a 6-month project. It was due to open in September. It has opened in September, and that's now up and running. And I think the mayor came and facilitated the opening of that back in September, as I said. So those realigned postcodes I've already mentioned. But we have also then, as a result of the ongoing pressure and the capacity at Northwick, but also the capacity at Ealing, we have been trialling further postcode changes to support redirection to the Ealing site. What we are seeing is what we saw in response to COVID is certainly London Northwest as a trust couldn't do without Ealing's emergency department and the skills and the calibre of that department in terms of responding to emergencies, but also the whole of Northwest London couldn't do without that capacity either. So you know, we're certainly continuing to focus on the A&E department in Ealing in terms of strengthening that. Miriam Harris, who many of you will know originally was at Ealing, she spent a lot of time at Northwick Park and is back now as the clinical lead for at Ealing Hospital. And we've begun our IT infrastructure upgrade in terms of resilience on the Ealing site, but also that will pave the way for us going live with our new electronic patient record system in August of next year. That we're due to take that in August 23. That will put us on the same platform. Hillingdon, we're doing it jointly as an implementation program with Hillingdon. They will go live in November 23, and that will put all 4 acute trusts on the same Cerner electronic patient record platform. That will significantly improve our clinicians' access to patient records and being able to update them in a more timely fashion, but also it will assist in terms of sharing information with GPs and strengthening patient care across the piece. And then in June of this year, we replaced the MRI scanner in the main hospital as well. So significant investment. I think there's just, have I got money? Yeah, over the page then there is the final slide then talks about the level of investment, capital investment we've put into the Ealing site over the last 18 months or so. So a real focus on strengthening the infrastructure, the facilities, the support to improve patient care on the Ealing site. And going forward, we are looking at plans in terms of continuing to think about how coming out of COVID, having recalibrated what is provided on that site. Mark is going to talk about the community diagnostics. I won't dwell on that. I'll leave him talk about that. But we need to think about is the site fit for purpose. So in terms of the A&E, it's quite constrained at the front end. We are looking at sort of what we can do to improve the footprint of the A&E department, but we're also looking at the overall use of the site and whether there's opportunities to strengthen it further. So we've got some external consultancy support in at the moment, looking at our development plan for the Ealing site. We work with West London Health, who share the site, not the acute site, but share the overall site with us in terms of what we can do together in terms of strengthening that and improving the site going forward. So I will pause there. Happy to take any questions of that, but maybe you want to hear from Mark at the same time and we'll take questions after. But
I think, and I've not asked anybody else, so I'm using the chair's prerogative here. I think it'd be useful just to see if there are any questions on what you presented so far, and then we'll take Mark and take questions on the elective, so that we're focused on. I would just start by saying we really value hearing from you and your colleagues about investment in Ealing Hospital and progress that's been made so far. And I share the ambition to try and drive that investment forward and look at the opportunities that are presented by what is a constrained site. Yeah, absolutely. But it's great to be having a discussion about how we can add more services and bring back services that have been suspended rather than the position we were previously. That's all I'll say. I want to take questions from colleagues. So Councillor Conti first, please.
Thanks. Yeah, that was really interesting. I had two questions. One was on, obviously, all the investment, everything that's happened, but what does that mean for patients in terms of people waiting for appointments, waiting for scans, waiting for operations? What impact is this going to have on the sort of the waiting list, and what sort of project over what time will that backlog come down? So what do you expect? And the second question was just on Cerner. I know in other trusts that have implemented, there's been quite a number of problems sometimes during the implementation period. I know when Chelsea and Westminster implemented it, there were issues with sort of clinic letters, etc., for a period of time, sometimes quite a substantial period of time afterwards. I'm just wondering sort of what lessons have been learned across sort of the number of trusts across North West London to ensure that it runs as smoothly as possible.
So in terms of the first one, question around backlog, then clearly we are focusing on the backlog and have been for the last 12 months or so. As a trust, we're now in a position where we are doing more than 100% of the pre-COVID levels of activity. Part of the national targets is that we get up to 107% of pre-COVID activity, and that enables us to earn what's called elective recovery funds. So from October, we are hitting that target. So we have got a focus in terms of driving down our significant backlogs. We no longer have any patients waiting over 104 weeks, and clearly 104 weeks is far too long to wait for an operation, but we did have those. We have none waiting over 104 weeks. We're focusing on the over 78 weeks and driving that down at the moment, and we're making progress in so that by the end of March we'd expect that to come down significantly. So that's in the low hundreds by the end of March. But we're also keeping an eye on the 52 to 78 weeks waiters as well. Clearly, we're prioritizing in terms of clinical need and risk to patient health, but we are putting increasing activity through our sites, and we're doing that through focusing on the diagnostics, trying to offer more first outpatient appointments, trying to initiate things like patient initiated follow-up, so there's less routine follow-up outpatients. So that frees up more outpatient appointments for firsts, and we are driving, you know, productivity and use of our theatres and trying to improve our booking systems and processes, so we're not cancelling patients on the day. And we've seen significant improvement in terms of our utilisation of planned theatre lists, as well as the utilisation of the theatre time. And there is national data comparing how hospitals do, and we are in the higher echelons now in terms of performance in those areas.
This is one very short follow-on question from that. Sorry, it was just, you said that by March would hope that the 52 to 78 week, I think you said, would come down to the hundreds.
No,
how many people is that now?
Yeah, I'd have to get back to you with the absolute figure. I wouldn't want to quote something that's been recorded in public without being the right figure. But it's the over 78 weeks I was referring to, not the over 52 weeks, because the over 52 is in the thousands. But I'll get you both those sets of figures.
That second question around
Cerner.
Yeah.
So one of the things we are fortunate with is that within Northwest London, there's a number of individuals that have been involved in Cerner implementation at Imperial, Chell West, and then they rolled it out to West Middlesex. So our chief information officer is a chap by the name of Robbie Klein. He was at Northwick Park 10 years or so ago. He then was the deputy to Kevin Gerald at Imperial. He was involved in the implementation, well, not the implementation at Imperial, but with Cerner then, but it's definitely involved with the implementation at Chell West and West Middlesex. And there are a number of other members from those, the original implementation teams working on the implementation at London Northwest and Hillingdon. And as well as that, there's clearly a big cadre of users of the Cerner system. So we are learning the lessons of their implementation, and we will be using some of their expertise and some of their teams to help us when we go live as part of the implementation process. But they are there as a critical friend and working with us closely in terms of that implementation plan.
Okay, so Councillor Weston was next.
Thanks very much. I really appreciate the presentation. Just a couple of questions from me. Obviously appreciate the investment sort of side of the presentation stopped at September. We'll hear about future proposals, of course, but specifically wanted to ask about winter pressures and how they're affecting the hospital right now. And linked to that, I'm really pleased that Councillor Conzi asked about backlogs, because for me there's something about winter pressures and how that might also affect the progress that we make on backlogs at the hospital, and just wanted to ask about that area as well.
Yeah, you're right. I didn't finish all the presentations. I need to go back to that, but let me deal with your question. So in terms of winter pressure, yes, all of Northwest London, like the rest of the UK, is challenged in terms of the emergency pathway, the demand on the front door, the number of LS attendances, but also the walk-ins and the direct referrals from GP services into some of the new initiatives we've put in place, like same-day emergency care, ambulatory care, frailty pathways, virtual wards, a number of initiatives we've put in place to try and avoid patients coming through the front door, through UTC and A&E, that they can go direct into those services and be seen more quickly and not having to wait long times, so that those who really do need the emergency care pathway can be seen effectively and efficiently. But having said that, given the scale of demand, there still are long waits that are not ideal. And we absolutely recognise that. So we have a daily absolutely rigid daily focus on that emergency pathway, the number of patients waiting for a bed first thing in the morning, the need to drive discharges through the day to free up beds to bring patients into a bed and therefore be able to run a safe A&E department. Your question then was about how does that impact upon our recovery and our planned and elective care. So at the moment, yeah, we're not cancelling any planned elective surgery as a consequence of that demand on the front door, and we hope that continues. One of the advantages of London Northwest is that we have got our central Middlesex site that is a cold site. It hasn't got an A&E, so we have shifted a lot of our planned care onto that site. So St Mark's, a lot of it's less complex procedures and services take place on that site. So that's freed up some capacity on the Northwick Park site in terms of bed, but also theatre capacity and resilience, and also our planned elective orthopaedic procedures always have gone through the CMH site, and therefore, you know, in terms of tackling backlogs around those and backlogs around ophthalmology that's also on that site, we're driving that hard in terms of that capacity on that site. And that, as you may well know, out for public consultation at the moment is a plan for an elective orthopaedic centre across Northwest London, and CMH is the planned site for that. So whilst I can't guarantee we won't have to cancel any, at the moment we're not cancelling any, and the way we've organised our services, we've got greater resilience than we had pre-COVID in terms of being able to cope with that.
I'll just ask if the position changes, Simon, if you could indicate that in future. I mean, hopefully it doesn't have to, because you've got quite tight rein on these things, but it'd just be useful for us to know so we can advise our constituents as to how best to. Right, I've got 3 or 4 more colleagues, including Councillor Mataza. I see you, Councillor Mataza. I'll come to you when I can, and then we'll move on to Mark's item. I just think it's important to get all of these questions asked. It's a useful discussion while we've got Simon here. So I ask other colleagues for their patience while we progress through this. Now, I am going to take a member of the public because it's my prerogative to do so. I'm not sure if it's going to be Eve or Judy.
I'd like to ask about the integration of the electronic records. And have you taken into account what happened at Guy's and Thomas's, where the whole system went down for 10 days and nobody could do anything? What's your backup plan? And have you considered that if you're integrating several hospitals, if it goes down, everybody stops working?
The first thing to say is we're not integrating the 4 hospitals. What we're doing is implementing a system that all 4 acute trusts will be running the same system, so we can share patient records across that once we go live. But it'll be a dedicated system for London Northwest Healthcare, as it is at the moment, using our existing systems. The same for Hillingdon, same for Imperial, same for Church West. So yeah. IT resilience is absolutely key for us in terms of, never mind with Cerner, here and now today, every day we are monitoring our system reliance and the operability. And it's quite timely in the sense that over the weekend we did an upgrade to our existing system, ePro. We've had some challenges with that, but in terms of preparing for that, we take a backup of the system before we try and implement the change. And therefore, if we implement the change and it all went down, we could roll back and bring up but the system as it was, as we saved it before we tried to do the changes. In terms of servers, we've got backup servers that we can run the system off. So over the last 2 or 3 years, we've significantly invested in our infrastructure and our backup systems and our cyber security, and touch wood, Yeah, we haven't been impacted in the same way that some NHS organisations have as a consequence of that investment. And we have independent audits of our infrastructure and our security every year, looking at those risks. And to be fair to NHS England, they've got quite a robust security process in place and gets alerts, and they're monitoring the systems and the firewalls and the intranets all the time and advising if there are potential attacks and or potential different malwares, etc. in terms of so our IT team, and we've got dedicated individuals that is their job, is just to look at the security and integrity of the system day in, day out. So I can't turn around and say it will never happen to us, because obviously it happens to big organizations bit bigger than us and with more money than us, but we are doing everything we can to try and maintain that integrity. And certainly when we're doing system changes, we spend an inordinate amount of time in terms of planning those and making sure that we've got the backups that we can roll back to that pre-attempt to do the change very quickly.
Right, so Eve, I've seen you. I'm going to no, not now. I'm going to try and get around everybody else. Whistle stop tour, and then we're left Mark waiting for about half an hour. So we need to hear from Mark. So I'm going to try and get you in if I can. Next was Mr. Cook, Alan.
Thank you, Chair. I've still got some concerns about the number of ambulances that are now turning up at Ealing Hospital. In April this year, according to LAS data, which I take is as gospel, since you haven't actually provided us any clear data throughout this presentation, we're talking about 1,300 patients coming in by ambulance. And if you look at the other thing, that across both sites, you actually have, of all the people that attend A&E, so not just ambulances, but everyone, 50% are still being needed to be admitted. And I think something needs to be done to ease that problem down.
We'll just say it's not just an Ealing problem in terms of ambulance attendees, but Simon, do you want to?
So we continually work with LAS. So what I would say, in response to COVID, all health organisations work much more collaboratively together. We share intelligence on the pressure of the A&E departments, the bed pressures within hospitals. So we can get diverts at particular times of the day if we think there are particular challenges. Equally, other hospitals get, so Hillingdon get from time to time, West Middlesex get from time to time, to try and help manage that demand. But there are particular days of the week and particular times where the whole system is swamped with demand for ambulances. But we do have an escalation procedure around the number of ambulances that may turn up in a particular hour that we can go. We have a trigger point with LAS that we say, hang on a minute, the department, we've got 7 ambulances to offload. You brought us 10 in the last hour. You can't keep bringing us at that rate because we can't offload. And therefore, that's when we get the diverts in place and the support. One of the things about, we clearly see this in terms of Ealing. Ealing is not of the same size and scale of Northwick Park. So Ealing can cope much more easily with those diverts and more ambulances during the traditional working day. But if we start trying to flood Ealing with additional ambulances in the sort of early evening period, sort of 5 to 8, 5 to 9 type of period, that's when Ealing gets into particular difficulty. So it's not just the number of ambulances, it's the timing of them and the frequency if they're all bunching up. So we have processes in place to try and manage that with LAS. But you know, we do have an inordinate amount of demand. In terms of the percentage of admissions, so earlier on I alluded to new pathways, direct referrals, avoiding A&E, so that reduces some of the denominator in terms of the volume turning up through A&E. So what you see coming through an A&E is those who are the most acute patients, and certainly traditionally those that come through the ambulance service are more acute, and therefore our percentage admissions for those who are turning up and coming direct into A&E, it's not, I'll need to double check the stats, but I don't think it's 50%. I think it's in the 30%. But again, I can clarify that data in terms of the percentage admissions coming through our A&E.
That'd be helpful. I would say on the data point in terms of the presentation, what we asked Simon and his colleagues to put together was a broad overview so we could drill down at this meeting on areas where we would like further information, and Simon and his colleagues have undertaken to provide us with that. So when we come to summing up, we'll look at where we want more data, and I'm sure we'll get that through. Councillor Mortaza, are you ready to ask your question? Lovely.
Thank you, Chair. My question is furthering Councillor Wesson's question earlier on about the winter pressure. The winter pressure is both on the hospitals and as well as at the general practice. One of the things which we have been encountering increasingly is the premature discharges from the hospital. And that also associated issue is with the pharmacy, the prescription, discharge prescriptions at the hospitals, and the waiting time in the hospital pharmacy is huge, and the patients who have booked transports or otherwise, they can't wait, and that comes to then put the pressure on the general practice. My question is that how we are going to reduce this pressure? Thank you.
It's certainly a fair question, and an issue I'm familiar with in terms of the waits for prescriptions for patients to go home with, and also in terms of transport. One of the things that we're trying to do is make sure that we're making the decisions around discharging patients earlier in the day, and facilitated that earlier in the day. What can delay that sometimes is the expectation that the patient's going home, but confirming the package of care. So if unless we know they're absolutely going home that day, then that delays the booking of the transport and the production of the TTAs for them to go home with them. And too often in the past, those decisions are not happening to early afternoon, and in some cases late afternoon. That delays everything else in terms of the booking of the transport and the production of the TTAs. So a clear part of our focus with our medical teams, we're insisting on earlier ward rounds and consultant-led ward rounds with their team, making the decisions around a planned discharge. If you're and also trying to make sure that we're working with our discharge team, that if we're expecting a patient to go home tomorrow, that we're doing the prep the day before in terms of trying to secure the packages of care and those kind of things in advance. So those are the sorts of things we're trying to do in terms of helping the pharmacy and the transport teams. But in terms of transport, we're also trying to improve the booking arrangement traditionally, and potentially the contract, because traditionally the model has been that they focus on bringing patients into the hospital in the morning, and then are available for supporting the discharges in the afternoon. So we're looking at that contract, and we're also looking at in terms of the resourcing and manpower in the pharmacy teams, in terms of making sure that they've got more capacity early afternoon to get those TTAs produced earlier in the day.
So I wonder if there's potentially a role for Ealing Community Transport in this equation to help with some of those transport needs. And there's certainly a role for us as a local authority in social services and care package provision. Kerry, I know you're indicating I need to get through the questions, and it may be something we return to, but I just think we're all aligned in trying to do these things collaboratively. I just think there are ways and indeed Councillor Mortaza's view and experience would be useful here. I wonder if this is something we can follow up on outside of this meeting, perhaps with a bit more information about what the pressures currently are and what we can deliver on. Yeah, John, I'll come to you if we have time, but it may be something we return to. Eve, you promised me no. That's what I like to see. Lovely. It's been asked. Brilliant. Right. Now, I'm conscious that Mark has been waiting for at least 35 minutes to tell us about elective. And it's very exciting that we've got this opportunity to talk about this new development. So Mark, why don't you take it away with maybe just a little bit briefer than perhaps we were planning, but don't diminish any of the salient points, please.
Thanks very much, Chair. Good evening, everyone. Hopefully you can hear me and see the CDC slide there.
Yes, we can. Go ahead. Yeah.
Great. I'll just move through this fairly swiftly. Just a little bit of background. I think probably most are aware that this is the CDC is a program to address the shortfall in diagnostic capacity in the UK and in England in particular. And actually the amount of diagnostic equipment per population in England is low, and that was very much behind the case for change and the development of a number of these community diagnostic centres, as they're known, across England, and these continue to roll out. And Simon earlier on just mentioned the 3 additional MRIs which are currently located at Ealing Hospital, which are very much the sort of first stage and the sort of forerunner of what we're developing over the next year or so. There's effectively 6 key aims of the diagnostic centres. I've listed them here. I won't read them all out, but this is very much addressing 3 core areas effectively. So it's recognising that there's increasing demand through our ageing population, and that's relevant in Ealing and across northwest London. It's also addressing the requirement for faster cancer diagnoses to support making sure that those patients that need to be on a cancer pathway are diagnosed early. So that's a second key point around this. And then the third one is very much to address that elective backlog that we've been discussing already, which is a result of COVID, and quicker diagnosis will help with that as well. So those are the 6 primary aims listed there. I'll just move on to the little geography around northwest London. At Ealing Hospital, there will be a CDC hub, and there are 2 additional what are called spokes, one at Wembley and one at Willesden, shown with the sort of number 1 on the map there on the right. And these have very much been in the design of the CDCs in the sector. These have been located around a number of factors, but one of those factors highlighted here is around particular clusters of deprivation. And we know that residents with more are more likely to experience those poorer health outcomes in some of those areas. So that is one of the reasons behind the choice in location. There were some other factors as well. Some of those are listed here, looking at population growth into the future, as I've mentioned, thinking about new housing developments and new transport developments, and also looking at the travel times to each of the sites. And that effectively narrowed down the process for the location of the CDCs and meant that when the decisions were made last year, Ealing was decided to be a hub, and as I say, Willesden and Wembley, the 2 spokes. There was also a comprehensive equality and engagement and health impact assessment process for each of those CDCs. I won't go through the full detail of that, but it was very much around making sure that there wouldn't be any adverse impacts against any of the protected characteristic groups, that the benefits would come through, and that the views of stakeholders, staff, patients and the public were taken into account as we developed the programme and as the design of the diagnostic centre was taken forward. And there were a number of workshops, particularly in 2021, as these were being progressed. At Ealing, it's a pretty comprehensive diagnostic suite which is being developed, listed there on the left of this slide. So you can see quite a substantial uplift. So these are in addition, these are a community facility, not a hospital facility. So these are in addition to the facilities already at Ealing Hospital. But you can see there 2 MRI scanners, 2 CT scanners, a number of ultrasounds, and other diagnostic facilities. So phlebotomy being the taking of bloods, and then some community cardiology and lung function testing as well. And probably most crucially, the expected timelines. So we're moving pretty swiftly on this, and colleagues may be aware that we're locating this at Ealing within our vacated old maternity building. So we have a building that is ready to go. We don't need to construct a new one. And that's meant that we are working ahead in expectation of achieving these timelines here. So we've appointed the architects and the design team. We've established a program and project board behind this, and we are now into the design period over the next few months before we will then go out to tender in the spring of next year. And we're expecting this to be between a 4 and a 6 month refurbishment program before we can open the first phase, which is those crucial imaging aspects of this diagnostic centre, and the community aspects of lung function and cardiology will then open in 2024. And currently, I'm pleased to say that we're on track for this schedule. That pretty much completes the overview. I'll stop sharing and, of course, very happy to take any questions.
I'm sure there will be questions. Indeed there are. I can't declare my interest, given that the Old Oak, Park Royal and North Acton was mentioned quite substantially in the housing development section of that presentation. But I should tell Ealing colleagues that I did have to defend Ealing's honour at the JOSC, where they queried whether this was an appropriate location. Fortunately, we put those questions to bed quite succinctly, if I may say. Councillor Conti, would you like to go first?
Thank you. There's lots about, obviously, the infrastructure, but what about the staffing? I was just wondering, obviously, all this takes radiographers, etc., obviously radiologists, etc., to then analyse the scans, or cardiology physiologists, etc. Where is the staffing coming from? And is there going to be new staff? And if so, are you confident in your sort of pathway to recruit them? Or are we jigging people around that already exist? Because otherwise it's great being able to have loads of scans, but who's going to read them and who's going to analyze them in a good amount of time? And just the second thing, there's a lot about surgery here, and obviously that's really important, but it's not just people waiting for surgery who are waiting on long lists. So there's people waiting to see cardiologists who then their heart failure gets worse and end up going in an ambulance to hospital, etc. What is happening in terms of trying with the other sort of medical outpatient appointments? Because I think we've really heard enough about what plans there are to reduce those backlogs. There's a lot here about surgical backlogs, but people waiting over a year to see a dermatologist, for example. So what sort of things are being done for that, and what steps are being taken?
Like you're reading my mind, Councillor Conti. So let's go to Mark for answer on at least one of those questions. I might refer to Simon for the second part.
Yeah, sure. If I just pick up the first point around the workforce in particular. So absolutely right. This staffing this centre is probably the most critical work stream actually in terms of the next year. And we've got a team assembled which are focused purely on that workforce work stream. These are largely new staff that we'll be recruiting in to run this, so they're not on the whole staff that will be rejigged or shared from the hospital. As I say, this is a dedicated community facility, albeit located at Ealing, and with its own entrance and exit, etc. Some of those staff that we need are in quite hard to recruit areas. You're absolutely right, and you picked out radiographers and sonographers as two of those. And so we are developing a recruitment and sort of retention plan as part of that workforce work stream. And we're starting that recruitment pretty early, actually. So we'll need to start, we've worked back, and we'll need to start early in the new year to make sure that we've got about a 9 and 10 month run in to make sure that we've got sufficient staff to open the unit as planned at the end of 23. Now we are obviously, I spoke about Wilson and Wembley, so we recognise that we're recruiting those staff across northwest London, and we are working with our other colleagues to make sure that we are able to attract those staff to the region as a whole, and in this case to Ealing in particular, rather than just competing with them for the same staff. But I don't say that this is going to be an easy task to attract those staff and to retain them. But it's an absolute focus of that work stream, and the numbers here, just to give you a sense for that, in terms of the when the unit is fully opened, we will be having just over 100 additional staff working within the setup, and that obviously opens over a phased approach. But initially, it's between 60 and 70 staff that we'll be recruiting next year to make sure that we can open on time as planned.
Can I take Simon on that second element around the other things we've got backlog on?
Yeah, so some of it I didn't cover particular specialties, but when I talked about the outpatient backlog earlier on, so some of the things that we are doing. So for certain services that there are that new initiatives in terms of access around things like heart failure, diabetes pathways, in terms of being put in terms of proving the access. But also what we're trying to do is generate more first appointments available. So those people who have been waiting a long time, we're trying to prioritize seeing those rather than the focus on follow-up. So what we are doing is looking at the job plans of our individual consultants and trying to make sure that we're clear in terms of the number of first outpatient appointments that they're offering versus the number of follow-ups. And we're looking at the size and the scale of the waiting list in terms of informing the proportion of first they're on within those job plans versus the if you like, the traditional way of working. So we are trying to prioritize those long waits, and in particular issues where we've got particular difficulties, then there is the access to mutual aid with other acute trusts across Northwest London. So in some specialties, then we've either provided support to others, like around ophthalmology for Hillingdon, but equally Chell West have provided us some support around things like gynecology, etc. So we're doing what we can to increase the appropriate capacity internally, but where we can't, we're having those joint conversations with other providers to try and provide appropriate access to patients.
Okay, can I just check who's got questions on this item? Because I've got one, and then it will now. Judy and Eve, or one of you or both of you? Right, briefly then, please.
Sorry, my question is actually to Mark about ongoing funding, which is really following on from the question that Councillor Conti made, which is that it's good to know, obviously, that the staff are going to be new staff. But what I was wondering, is there recurring funding? Because very often with these Northwest London developments, what you actually, or elsewhere, is you get an amount for the capital, some amount for staffing, but then it does not continue. So then the burden falls back on a trust like yourselves, who are already obviously struggling for, it's not easy financially. So I wonder if you could say something about how recurring, if it's going to be recurring funding.
Thank you, Evie. Yes. There's two aspects to the funding. You're absolutely right. There's the capital piece, which is obviously for the infrastructure, and then there is a revenue component, and it's that revenue piece which is the funding for the workforce and for the staff. And that is on a recurring basis, and we know what that looks like for the first 4 years of the CDCs. Obviously, projecting further ahead than that is difficult, but in terms of the capital and the revenue funding for the CDCs, that is the current sort of situation and the sort of allocation that's been given at this stage. Evie.
That's good. Did you want to ask a question? Sorry.
Didn't think I'd have that privilege. From my past experience as a consultant, we were always very integrated with respect to the diagnostic services. Now, ultrasound is a particularly subjective subject and depends very much on the skill of the ultrasonographist. What are you going to do to make sure that people who make referrals write decent histories so that the diagnostic person has some idea of what they might be wanting to look at? I think there needs to be a major educational program to make sure that the referral system is very detailed. Otherwise, you'll get rubbish.
Forthright as ever, Mark.
Yeah, I'll happily start on that. I think it's a really key point, isn't it, in terms of the quality of the referral is crucial to make sure that the diagnostic that then's carried out is done appropriately. We do have, I think this is two things. Firstly, working increasingly in an integrated fashion and alongside our general practice colleagues to make sure that we continue to have regular conversations, regular interface meetings, making sure that we're talking about that. And that is very much in place already to make sure that where things aren't right, either from the acute side or indeed from primary care, that we can talk about that and put it in place. And what I'd also say as well is this is where I think to some extent the technology can help us somewhat in terms of making sure that we've got sort of good and accurate ways of where appropriate electronically referring in, which of course helps in terms of making sure that there's a thorough history and a completed form for that referral.
Simon, I'm going to take, well, I'm not sure who I'm going to take first. I've got you and I've got Dr. Taylor as well. So let's start with you and then let's go.
Just the other point I was going to make is that London North West has got its own ultrasound academy in terms of training sonographers on the CMH site. So we think we have a particular level of expertise and skill internally within the trust, but we still rely on a decent referral. But in terms of the skill set and our ability to train those staff coming through, it's absolutely crucial.
Taylor, you want to come in, please?
Yeah, just to add that we've also developed smart referral forms in terms of how GPs complete those to prompt them in terms of best practice and guidelines, but also our ICE platform that we now use for radiology request likewise does the same thing in terms of ensuring that the correct clinical history is captured in that platform.
Right, I'm tempting fate here. I'm not seeing any more indications, in which case I'm going to try and sum up. It wouldn't be an Ealing Health meeting if we weren't running at least 20 minutes behind schedule on the first item. But, you know, here we go. Right, I'm going to try and sum up some of what we've heard and make some recommendations with the agreement of colleagues. Look, first of all, I think it's important to reiterate how positive it is to be able to have this dialogue with Simon, who I normally say is no relation to me at some point in these meetings, and it's important to underline that. But I do think the tenor of the conversation shows how the local authority and our NHS partners are aligned in our thinking and in our collaborative working. It's really good to see the improvement at Ealing Hospital over a steady period. And as I said before, brilliant to have ongoing investment. And I think the points made pertinently towards the end of that last discussion about the importance of national funding and recurring funding for at least the early part of this CDC element is really welcome. What I would say, just 2 points to close on. So there are a couple of things we're going to take out of Simon's element of the presentation in terms of some more data we're going to get. One of the things, I don't want to speak for Councillor Steed, he can speak for himself if he disagrees with me. One of the things that came out of our visits in September, Simon, that I was very struck by was the commitment of the trust and the staff to use this investment as an opportunity to invest in training, in education, in development and retention of staff at Ealing Hospital as a whole, which is so important given how more expensive it is to live and work in West London as opposed to other areas of the country. And so that was something that came across very strongly in our visits and we were very encouraged by. Similarly, I do think having the CDC in place, having the elective centre, I'm not going to call it a hub for historical reasons, if anything else. Having the centre in place will help with that. And I did just want to touch on the places identified as places of deprivation, because colleagues will want to have a say in this. The presentation spoke of Hanwell, Southall and Greenford in particular as places of relative deprivation, and I know colleagues will have their views on that, but it is absolutely important, if this is to work, that we all work with those communities to shape the services so that we can deal with those health inequalities and hear from the diverse elements of our community in those locations. So I do hope that we can continue to work together and hold some events with the local councillors, with the local residents groups, with the campaigning organisations, with the residents themselves, so that they can shape the future of these services. Because although some plans are laid down and we'll have to follow those through, you know, there's a way to add value here, and I think that would be that would be really welcome. So that's why I'm going to pause this with our, and I would want to reiterate on behalf of the panel, our immense gratitude again, Simon, to all of your staff, to everyone who works at Ealing Hospital for the period that we've been through. And we did hold an event last year or in the summer, trying to emphasise that, but it's a very difficult time for the NHS. When is it not a difficult time for the NHS? We're about to go into another one. But, you know, we're very lucky to have such high quality services and to have staff that continually go beyond the call of duty. And if you could take that back to your teams and to everybody, we'd really appreciate it. So thank you to Simon and to Mark for presenting on those really important items. Hopefully we can schedule in a progress report, both from Ealing Hospital and Mark, on the progress towards that exciting development, aligned to those sort of scheduled progress milestones, if you like, going forward. Thank you to both of you, and I'm sorry to colleagues who are going to have to follow that because we're slightly later than billed, but in which case I'm going to move on to item 7 first of all, which is our mental health beds discussion. I'm delighted to be joined this evening by Dr. Chris Hilton, who's no stranger to this panel. Let's get this right and in the right order. By Richard Mountford, the Deputy Director of Communications and Engagement, and Sonia Clinch is the Clinical Director for Acute Mental Health Services. Hopefully I've got some of those names right and titles at least. Chris, over to you, and then we'll take questions and a discussion will ensue, I'm sure.
Okay, thank you very much, Chair, and thank you to colleagues for joining me this evening and for the opportunity to share with the panel the work that we're currently doing in West London Trust regarding the acute adult mental health beds on the Ealing and St Bernard's site. I'm going to be trying to steer through the presentation whilst speaking, so bear with me 1 second. There we go. I hope this will allow us to work. Great. So the headlines are that, as many of you will be aware, West London Trust covers the boroughs of Ealing, Hounslow and Hammersmith and Fulham. And certainly for as long as I can remember as a clinician working in the trust, we've operated our inpatient services across a 3-borough footprint. So the definition of in area for West London Trust is that we would admit patients as close to home as possible, but across the footprint of the 3-borough units that we serve. Amongst our sites, the Wolsey Wing and the old St Bernard's Hospital is the oldest of our estates, predating the NHS by over 100 years, dating back to 1831. And it is repeatedly been identified as no longer being fit for the delivery of modern mental health care. During the COVID pandemic, we had to suspend the use of 31 beds in the Wolsey Wing. There were a number of reasons for doing this. One was around staffing pressures at the time with a number of staff absences, but also particularly due to our inability to provide safe care in that environment related to infection prevention and control and the separation of and the ability to safely isolate staff within that building. Patients, I should say, within that building. Just to be clear, what we're discussing at the moment has been in place on a temporary basis since the start of the COVID pandemic. So for the last nearly 2 years, we have been operating with the current model of bed provision that I'll come on to describe. We suspended 31 beds. We had a ward that was available to be reopened in a more modern building, which was the 18-bedded ward on the Lakeside site next to West Middlesex Hospital. So the net change in beds in total was 13 fewer beds. And the purpose of presenting today and the current period of engagement that we are participating in is to make permanent some of those arrangements. And I really want to emphasize two things. This is about the quality of care that we're able to provide within the estate that is available to us, and not at all about financial considerations. All of the investment that would have been spent on those inpatient services in its entirety will be ring-fenced for the delivery of acute mental health pathways for the benefits of the populations that we serve. So just to, I won't go through every slide in this level of detail, but just to summarize the purpose of the conversation today, we have been going through a process over the last 12 months to develop a proposal including researching, looking at our data, doing different levels of engagement with individuals to seek to put together this proposal. And we've worked with a number of individuals and organizations and specifically taken advice from the NHS England and Improvement London team about the next stages in making permanent these changes. So the proposal had been to come to this committee because our belief is that the scale of the impact that we are proposing will most impact residents from the Borough of Ealing, and to seek your support to enter an enhanced engagement phase. Unfortunately, due to the death of the late Queen, the panel in September was cancelled. And in consultation with the chair and the vice chair, we also presented to the Joint Health Overview and Scrutiny Committee in early October and proceeded with the enhanced engagement process that we're now currently in, knowing that this committee in late November would fall within that period and an opportunity for scrutiny from members of the panel. So I just wanted to talk through the stages that we've been through. And they involved identifying the context for what we're trying to do, developing a case for change and why we would wish to do it, developing a proposal, and then identifying what the next steps would be. And there's a lot of information in this pack and not a lot of time in this meeting. So I trust that a lot of people will have been able to read the pack in advance. But really just to emphasize, this doesn't in any way reflect our commitment to the Ealing Hospital site. We will continue to deliver a number of services on the Ealing Hospital site, with most of which are our specialist services. And we have a number of other services for adults in mental health crisis and older adults in the Borough of Ealing, with no plan to change that. But we do wish to proceed with a recommended approach within this enhanced engagement document with the option that I'll describe later. So just to clear, what we've done is suspend the use of those 31 inpatient beds for adults with mental health problems, and reopen 18 beds on the Lakeside site. In addition, we have enhanced and made permanent or made recurrent, if this proposal continues, the staffing for our health-based places of safety. That is where individuals get taken in a mental health crisis, both at the Charing Cross Hospital site and the West Middlesex Hospital site. And we have made some augmentation to our single point of access and set aside some investment for addressing transport concerns that residents from Ealing may be concerned about, and also to invest in some step-down provision, which will support us with the flow of patients to our inpatient units. And the diagram on the slide that I'm showing at the moment gives you an indication of how that ring-fenced investment will be retained. I'll just move forward to a few slides ahead. And just to give you some information about the position prior to the suspension in March 2020. So over the year running up to the COVID pandemic, a total of 550 Ealing residents were admitted to adult inpatient mental health care. During that period, we treated about a third in Ealing, about 23% in Hammersmith and Fulham, and about 40% in Hounslow. So this change, it was always the case that Ealing residents were being admitted to our more modern units in Hammersmith and in Hounslow. But the change that has happened since with the suspension of the beds means that a considerably larger proportion of Ealing residents are now treated primarily in the Hounslow beds that we have opened. I also wanted to just highlight one other thing. We are almost unique amongst mental health trusts in our ability to manage within our bed base. So despite the ongoing pressure on mental health services that you'll all read about, it's been in a lot of the newspapers and is a recurring anxiety. West London Trust, it remains the case that even with the suspended beds over the last 2 years and the added pressures of the last year, we have not had any unwarranted use of outer area placements for patients who needed an admission. And I will qualify, what do I mean by unwarranted? The only circumstances in which we've had out of area placements and purchased beds in the private sector are where individuals have needed a female psychiatric intensive care unit, which is a service that we're not commissioned to provide, or individuals who tend to be staff members within our own organisation, and we choose to admit those for in an out of area placement for obvious reasons to support the confidentiality of that individual. You'll see in the pack there's information about the impact on travel time and the history behind some of the changes that have been happening. We've also shared some of the benchmarking around where West London is in terms of the number of beds we have compared with our 8 or 9 mental health peers in the capital. And this is the penultimate year's data. The new data has just been published, but for the weighted population, we're around about middle of the pack. So there are a number of trusts that have fewer beds than us. The other thing I just wanted to highlight to you, we currently operate with a length of stay within our acute mental health wards on average of around the late 30s number of days for people to be admitted. And we've done some modelling to see if our length of stay were to increase, because the complexity of cases might increase, would we be able to operate within that bed base? And our modelling suggests that we would be able to, with some increase in length of stay over and above 40 days, which is above what we are currently operating on. So from our data analysis, the sense was that the number of beds that we have at the moment is about right. There was a mismatch between male and female, and one of the things that we've been able to do with the more modern ward is split and have a mixed gender ward with appropriate segregation and privacy facilities. I'm just going to move further forward to explain what we've done. So we've talked about the discovery phase. We've also done some early engagement with a number of organizations, individuals, etc. And on the basis of that early engagement, we also undertook an equality health impact assessment. Individuals who want to read that in full can see it on the Trust website. It's also being presented to the Health and Wellbeing Board. And we started developing solutions. You can see we looked at a number of solutions, including do nothing, continue with our current provision, reopen Hope and Horizon wards with basic or full renovation, and then look for alternative provision in various different facilities. And a panel looked at these different options to try and narrow down the number of options we were looking at based on the criteria that you can see. And the preferred options within this were to maintain the position that we've been working on and operating with for the last 2 years during the COVID pandemic. And that is to keep open the 18 beds that we have in the more modern facility at Lakeside, the additional staff in the health place bases of safety, and the other step down and other acute support that we have in place. The other option was to see if we could identify another inpatient building that would allow us to keep the beds in the borough. And I suppose it's worth highlighting that our property team undertook an extensive search for suitable premises within the borough of Ealing and were unable to find a facility that would allow us to provide suitable mental health beds in the borough. So that led us to the preferred option for option 2. And I'll just move slightly further forward. There are a number of equality health impact assessment aspects, and we were seeking to respond to some of this because there is an impact for residents of Ealing, and I'm not going to pretend that there isn't. But we were seeking to mitigate that by exploring options to support the travel for relatives and patients, looking at how the quality of the environment will be improved, making sure that we aren't disproportionately affecting people with protected characteristics, looking at the impact on our workforce, and making sure that the facilities that are going to be provided in the alternative premises are definitely superior. There are specific tests that the NHS needs to consider when considering a change. And that is to undertake patient engagement, to consider patient choice and health inequalities, and to make sure that there is a clear evidence base and clinical support for what is happening. Also to gain support from commissioners and to look at the overall bed capacity that we have. You can see in the responses to these bullet points how we believe that we are attempting to address some of those tests. And the view in consultation with NHS England at London region level was that it was appropriate to proceed with a period of enhanced public engagement, which is a period that we're now in. And we wanted to be as robust as possible in that enhanced engagement period. So to all intents and purposes, this is akin to a public consultation that will then allow us to put together recommendations and a decision-making paper that will be available for scrutiny later in the year. I think that probably summarizes the key features, but I'm happy to take the inevitable questions.
Thanks, Chris, for both your detail and your brevity. If those two things are not contradictory, I've got colleagues waiting to ask questions. I would just preface this with an acknowledgement of the difficulties of the site and the history of that site. It's clear that the two wards are not and have not been, Chris and I have toured that site previously. I've toured it with Chris's predecessors. It's not suitable for use at present. And I don't think anyone disputes that. The issue for us here in terms of scrutiny is how we add value to a process that has already begun. And the likelihood is that this is the only option seemingly from what you've just outlined that remains on the table, and how we get the best outcomes for Ealing residents. I would just say, we touched on enhanced engagement and public consultation. Both of those phrases probably have the ability to get us into some degree of difficulty if we're going to have the type of conversation that needs to be had. I would just say my personal view at the moment is the level of consultation, the level of public awareness about these proposals within Ealing is low, to the extent of being non-existent, frankly. And that is clearly unacceptable in terms of making robust decisions. And then it's about how we, inform our residents. But, there are lots of people in mental health crisis up and down the country. None of our mental health services nationally are properly designed and able to cope with that. None of that is, I think, in dispute. So it's about, and you referenced the fact that we would have had an earlier conversation, had events not conspired against us. if you like. So I welcome the opportunity for the panel to ask questions, and I welcome your commitment of saying that you will return to this forum and other forums when your proposal is in a stage to talk more substantially about what you plan to take forward. And in that spirit, I've got Councillor Alexander has been waiting for some time to pose her question or questions. Councillor Alexander, are you ready?
Yeah, I'm ready. I've got 3 questions. In terms of the support for family, and just to let you know, I used to work for West London, and I know the wards, and I understand it is a good idea, but I just feel that in terms of the travel, I know that some families might not necessarily know that I just want to make sure that this would be safeguarded. I know sometimes there's cuts. So will you assure that Ealing residents, family and friends and service users have access to that travel? Access, if it's money or transport. Secondly, I also wanted to say about that I feel that there possibly will be pressure on ECAP, which is the crisis team, and obviously our recovery teams. And I know that sometimes there are staffing issues in terms of ECATs. So I'm just wondering, how are you considering that pressure, especially with staff who will have to manage their caseload? And also on page 10 of the report, there was something about BAME communities stating about that you wanting to have a less reliant on inpatient services. Can I just get a little bit more information in terms of that? Thank you.
Chris, do you want to come back on all 3 of those? Yeah.
I can, and I'll start, and my colleagues may wish to come in on some of the aspects. In respect of the patient transport question, which was the first one, I guess what I can say is that we are inviting suggestions about how we can, as part of the consultation, about how we can best meet the transport requirements in a way that is fair, robust, and sustainable. There is ring-fenced investment available for us to mitigate the impact on travel, not only for patients, but also the people that will need to visit them during the course of their inpatient stay in a neighbouring borough. So the best I can do is give my undertakings to the panel that it is absolutely our intention to try and mitigate that, mitigate the impact of being admitted to a neighbouring borough. But we need also to come up with a proposal, and there are ideas I think that are part of the consultation, but we're also inviting others. The things that we are exploring is whether we can work with community transport providers, to name check colleagues in the room, or others, or also whether we can identify ways of reimbursing individuals, but also to acknowledge that in a time of considerable financial pressure, a reimbursement scheme does require an individual to pay up front. So we are mindful of that and keen not to challenge. The second point was around the pressure on community services and staffing. We have been, as I said at the beginning, operating with this model of care for nearly more than 2 years now, with the suspension of the wards, and we are aware of the role and the importance of our crisis alternatives. There are a number that have been put into place as a result of this change, and a number that we were doing anyway, including the safe haven that we run with Mind in the Lido Centre, as well as the crisis assessment treatment teams and various other things. I think you're absolutely right to highlight the risks around staffing and vacancies, but I don't foresee making a decision to make something that has been an interim arrangement permanent would in and of itself worsen the staffing difficulties that we face in other parts of the organisation. And I haven't got the pack open in front of me with respect to the BAME question. but I don't know if Sonia wanted to come in on that.
It wasn't about that, but it was about the crisis team. Oh, sorry, can you not? Can you hear me now? Is that better? Just to comment about the crisis team in Ealing. So we're aware it's a big borough, and during the last 2 years, we've actually separated the teams. So there's 2 teams, it's not just one, and we've recruited 2 team managers in there. In addition to that, we've also in the process of recruiting a matron, which is a senior in-reach post to work into the wards, both in Lakeside and in Hammersmith and Fulham, just to acknowledge that. So that's additional work that we're doing.
And I have just quickly looked at the pack, so I now can see the statement around the importance on BAME communities of reducing the reliance on inpatient care. The Trust committed to reducing restrictive practices and to delivering care in the least restrictive setting possible. And as part of our examination of the impacts on different communities, we are aware that there is a greater proportion of individuals from BAME backgrounds and certain particularly also Afro-Caribbean backgrounds admitted to mental health facilities. And when they are in mental health facilities, that they are at times more likely to be detained under the Mental Health Act than to be an informal patient and to experience restrictions whilst they're there. As part of our commitment to reducing the restrictive practices and addressing the inequalities, I think our belief is that we can focus on making sure that we have culturally appropriate alternatives to inpatient admission.
Just to follow up on that last point, and I don't want to follow up for Councillor Alexander, so I'll ask her if she wants to come back in a second. There needs to be some recognition of the ethnic diversity, not just of Ealing, but of Hammersmith and Fulham and Hounslow and the surrounding communities who will be affected by this proposal. When you talk about culturally appropriate replacement for what is currently in operation, how diverse and representative do you think your engagement to date has been with those communities to help co-design those services at present?
I think there is some information that we can share with the panel, and I don't know if the slightly updated pack had been circulated, or well, I'd be certainly very happy for that to be shared. We are very conscious of the need to ensure that we are engaging with the diverse communities. We are due to have a review of the engagement feedback to date in the next few days, which will give us a steer as to the diversity of the responses, the audiences we have had responses from to date, and will support us. But one of the things I would be very keen to do, and I'm sure as one of our engagement leads, Richard might also want to comment, is invite any support that we can from anyone in the panel or in the room to support us to engage with communities in a way better than we have done. There's always more that we can do. And your initial comment, Chair, about the knowledge of this in the community, despite a very huge amount of effort from Richard and his team, we're very happy to do more.
Did you want to come in on that specific point, and then I'll go back to Councillor Alexander?
I think, as Chris is saying, we acknowledge this is a challenge for us. It's been the first half of this engagement period. This bit has been the one where we probably think we need to do more. The midpoint review is happening this week, as Chris has said, and I think reaching out through voluntary sector organisations, which we've tried to do so far, is going to be a priority for the second half of the engagement period, no doubt about it. But yeah.
Sorry, Councillor Alexander, I did speak for you in responding. Was there anything else?
No further questions. Thank you.
Okay. Then I'm going to go. We'll come back to some of those points raised. Councillor Wesson was next.
Thanks very much for the presentation. You made a passing reference, I think, to mixed gender services, and I didn't quite fully understand what you were saying in relation to that point. I am very much aware that in 2018, the CQC published some research which highlighted mental health inpatients' concerns about potential sexual harassment and abuse. So I just want to get an understanding of what it is you're proposing in relation to mixed gender services. and link to that, whether that has been reflected in the EQIA, which I'd quite like to have a look at in a bit more detail.
So I'll start, and Sonia might wish to comment, and she's been managing some of these services during the interim period. The approach that we take in the trust is that we have single-sex wards across our estate. We, in order to manage at times where we have a particular peak in male admission demand or female admission demand, we have identified one ward, which is Robin Ward at Hounslow, which is the estates of the ward allow us to have gender segregated portions of a single ward, and this has been reviewed by our nursing directorate in conjunction with the Care Quality Commission to ensure that they are satisfied that that particular facility is able to provide safe care that meets the requirements around sexual safety, particularly in an inpatient setting. Sonia, I don't know if you wanted to add anything.
Not really. I think, Chris, you've covered most of it, to be honest. But we did do a walk around before we opened it. We did quite a lot of work, as Chris has already mentioned, with the CQC, and they came and visited the ward and were very clear that at the end they were happy with the decision that we'd made in terms of how you could divide it.
But that's really the exception, and all of our other wards in the organisation are single gender.
Thank you, Councillor Conti.
Thank you. It was just really about the sort of future resilience of this proposal in terms of obviously the keeping things in terms of status quo, in terms of what the provision is at the moment. Obviously, there's a lot of development happening, not just in Ealing, but in Hounslow, Hammersmith and Fulham, etc. I think there was something on BBC News yesterday about NHS Digital saying between 17 and 24-year-olds, a quarter now have some level of sort of mental health problems. And obviously, there was varying degrees of that, and we're talking sort of one end of the spectrum here. But you know, in terms of this provision, how long do you feel that this will be able to maintain the demand? And obviously, at what point would that be reviewed, and how could that be changed in the future? Is this sort of just looking very much in the short term?
It's a really good question, and one which I think is extremely prominent in our mind. This is not the only thing we are doing with our inpatient beds. So in terms of the current engagement period and the proposal that the Trust is recommending, we're really trying to make permanent the closure of the currently suspended beds to move us forward to focus on some of the other priorities that we're also doing. Those other priorities include a huge amount of work looking at a program around patient flow. This mirrors very closely exactly what you will hear talked about through our acute colleagues. We find that and Sonia is an expert in this, and I'm sure she will want to add, but we've got a whole pathway approach to managing individuals in a mental health crisis that includes alternatives to admission, and we've expanded those alternatives to admission in the last few years and would like to continue to do so. We're testing further expansion during the winter period. We are also needing to make sure that we've always got available mental health beds in our local area within the 3-borough footprint for individuals that need them. And I'm pleased to say that, you know, we have a pretty good track record of not having significant waits for individuals who require an inpatient bed, which is not a mean feat in the current climate in London. I think that the third thing that we then need to do is make sure that the individuals are receiving therapeutic interventions at the right intensity within the wards while they're there. That includes ensuring that we've got therapists and medical staff and a rapid, confident diagnosis and treatment plan 7 days a week for individuals that are admitted into our wards. And then also that at the point they are ready psychiatrically, psychologically, socially, medically, to move to a setting closer to home, that we're able to move them on. And there's a huge amount of joint work going on, including with the council, to make sure that individuals are not waiting in our beds for something that doesn't need them to be in a bed. Part of that has involved us working with the local authorities to develop step-down provision. So this is when individuals are medically well, they can be stepped into a sort of supported housing environment. And to develop a reablement team so that individuals can leave and go home and continue to receive support and care post-discharge. So there's the whole pathway is about making sure that we've got the availability of the beds and the flow, and also looking at our length of stay. We are, as I said, looking at the late 30s in the number of days for our average length of stay. There are a number of other organisations have a shorter length of stay, and clearly there is a balance, because we want to make sure that beds are available for as long as people need them, and I don't want to discharge people prematurely. But on the other hand, we have modelled on that slide that I alluded to earlier on, the ability, if we have the number of beds that our modelling suggests we need with a length of stay of 40 days, there is room for that length of stay to increase, or for the demand to increase, before we hit a problem. So I think with all of those pieces of work that we're doing to support our length of stay, to reduce the number of patients who are in the beds that don't need to be in them because they could be in a better place, the sort of delayed transfer cohort, our view at the moment is that we can manage for the foreseeable, but for which I mean a number of years. And I think the question around demographic growth and population growth is one that we're also keen to model in, and we hope that a proportion of that can be met by some of the flow work that I've described. But ultimately, this is about trying to really remove the risk of being admitted to a facility that's not of sufficient quality or safety.
Conti, indicate you want to come back, yeah?
Just very briefly, just on obviously you spoke about obviously avoiding people being admitted in the first place, and ensuring that they get the interventions they need. Are you confident that that demand growth there's going to be an increase in demand at that lower level? And in terms of the capacity that's there to ensure that people don't deteriorate and escalate to require those beds, in the years ahead, how resilient do you think those lower sort of rungs of the ladder are?
And to answer that, I think reasonably is the answer. I think there is more work to do. You'll be familiar from conversations in Ealing and perhaps from your clinical experience of the changes that the Mental Health Trust is halfway through, which are related to the community mental health framework. It is important to us that our community services are as resilient as possible in order to prevent deterioration to admission to requiring a bed, and that's why in a separate part of my job there is a huge amount of work going on to ensure that we are making the most of the additional investment we have received in community services to make sure that they are resilient.
Simon, did you want to come in on this particular point?
So it's linked to things that Chris has said. It's just a quickie, really. So Chris has said a couple of times into the ability to admit patients. So clearly, within the A&E department, we often have on Ealing site patients waiting for a mental health bed. And what I would say is there's a complete distinction between the ability of West London to admit quickly into an acute adult mental health bed compared to CNW at Northwick Park. So I could just reiterate that we don't experience significant delays from an acute trust perspective in terms of the mental health trust in Ealing being able to admit patients requiring a bed.
Councillor Steed.
Thank you, Chair. Can I just go back to this question raised by Councillor Alexander about transport and support for families? What have you been doing over the past 2 years? We asked that the beds have been suspended. That may be different from what you plan to do if this process is formalised and completed.
I'll look to my colleagues to correct me if I'm wrong, but I don't believe we have been reimbursing individuals who have been inconvenienced by being admitted to neighbouring boroughs. To the best of my knowledge, I think the suspension that took place during COVID, and frankly prior to that, when a significant proportion of Ealing, 2/3 almost of Ealing patients were being admitted to neighbouring boroughs. It was not something that we'd supported. The reason we're proposing it now is it was, and I suspect in the context of the current financial climate, it is something that has come back to us during the early engagement that we've done, and it's something that we are certainly willing to address, and we recognise the challenges that it will bring.
Do you want to follow up, Councillor Singh?
I suppose only in as much as I suppose I'm getting at, yeah, it clearly is an issue, but I'm just asking, I suppose, how big an issue is this? I'm not trying to dismiss it in any shape or form, but if it's a service that you weren't providing, but now you're going to provide, I'm not being critical of what you haven't provided necessarily, but clearly there is a demand for it, I suppose, but people would just have to bear the cost themselves.
I mean, I guess we have done some transport analysis that looks at the impact of, on car journeys, on use of public transport, etc. And I guess one of the reasons why it's in part of the consultation is to help us understand individuals who feel that they will be particularly adversely affected. And we need to come up with something that is both reasonable and sustainable. But I definitely take your point, which is, if we haven't been providing it, why is it a problem? But it was one of the themes that came out in the early engagement, which is why we're keen to address it.
Right, so it is a problem, and we'll get to the reasons for why it is a problem in a minute. Councillor Alexander was indicating, and then I'll come to you, Nahar.
Oh, hello. Hi. Yeah, I was going to say, obviously working in West London, there was times where there were no beds in Ealing and service users would go to Hammersmith or Hounslow. That's, and families would be concerned about, the financial, difficulties getting up to Hammersmith, for example, or Hounslow. So if this is, I'm a bit concerned about that, in terms of this has been going on for a long time. So I'm, what's been happening in terms of service users and their family, and especially because of the cost of living crisis, have you got any information in terms of were people less likely to visit their family members in hospital, or could you just sort of give us any feedback on in terms of service and family feedback in regard to that?
Councillor Alexander, I'll try to respond as quickly as I can. I think it takes us slightly away from the engagement question, but what has happened over the last 2 years has been an evolving picture. And in fact, it's probably fair to say that visiting was somewhat restricted for a significant period of that time because of the COVID restrictions. So that's one of the reasons why, I think we're very keen to ensure that through the engagement period, we are exploring this to the best of our ability and coming up with a plan that we feel will meet the needs for those who need it, but recognizing that not everyone will need it.
I'm going to take Nahar, and then I'm going to ask some questions.
Thank you. So for me, I was part of the panel, and I'm asking some of these really pertinent questions, and I'm also part of the review process and about the engagement in particular. And I think this is why it's so important that the approach to engagement, and I hear that not many people know about this, is partly because not many people would have used that service in the first place potentially. But what the trust has done is written to all of those that have used it in the past few years, and then understanding their experiences and their concerns and what they would want to see out of that is really important in the absence of being able to do much wider engagement. But I think there is so much more that can be done. I think the processes, the support for patients going into the service or pre, to sort of prevent them deteriorating to the point where they need the service, or when they have been in the service and then come out, and the discharge support and the support back out in the community is so important. And I think that's what the funding would really potentially support, with making those pathways really robust.
Right, okay. This is really difficult, frankly, because whilst we recognise the difficulty with the current provision and the fact that it's not safe to continue commissioning and using that provision. None of us, I think, wants to sit here and endorse a proposal that cuts mental health beds within this borough. You know, I'm fairly confident that everyone would agree with that assertion. Since the agenda has been published, I've been contacted by some of my own constituents, then people who have used the service, and then people who can't use the service at present because the capacity is not there, right? Or they feel that their needs cannot be met, or they read things in the newspaper like the articles that have come out over the last few days, referenced by Councillor Conti earlier, about pressures within the service. And I'm speaking about the youngest cohort of my constituents and of society present. And I just want to try and summarise it in this section, some of what they have told me, because it is impossible to do it justice in the time we have. And I want to allow even her colleagues the opportunity to ask some of her questions as well. The main issue that has come through the correspondence I have received is that clearly we are, in this proposal, going to take away some of the service provision within Ealing that may not be able to be used at present, but is at least there in terms of that bed provision. And the impression that leaves for some of those people who need access to this service, or need access to CAMS, or need access to the community services that Nehar and yourselves have referenced, is that it's going to become more difficult as a result of these proposals. Now, maybe that's a flaw in how these proposals are presented, but we need to do something to address those concerns, because there is a mental health crisis. Many people are not confident in describing their mental health symptoms at present. People are doing it more as a result of the lockdown and as a result of the period that we've been through. But, you know, I do at least want to address the issue that there are many people who feel they can't present with their mental health symptoms at the moment, not because of a fault, not because of anything that you're commissioning, but that they can't get access to their services through their general practitioner, through the services that are in the community at present. And now they see this as a potential barrier to access. And that's what I'm trying to present to you this evening from them themselves.
I guess the invitation to respond to that, Councillor Crawford, I completely recognise the concern that individuals will have that this would appear to reduce the provision of mental health care for Ealing residents. I guess what I would respond to those individuals, your constituents, is that the evidence that I presented earlier in the pack, this is about the individuals requiring an inpatient crisis mental health bed. And I recognise there are pressures all over planned care for mental health, not only in West London Trust, but elsewhere, as you've described. So I'm looking specifically at the individuals who require an inpatient admission, which remains a very small proportion of individuals with mental health needs. And certainly our experience over the last period has been that Ealing residents have access to a sufficient number of inpatient beds in the configuration that we currently have them during the suspension, which has allowed us to test this over the past couple of years. And I guess what I would seek to do perhaps during the next few weeks is explore with those individuals how we can ensure that we can support their understanding that we're talking about the most acute presentations, and that the availability of access for individuals in mental health crisis to a bed when they need it in the local area, which I'm defining from a trust lens, although I recognise that individuals and residents of the borough might think of as a borough lens, remain available. I think there's two or three other things I'd just add very quickly. One is around the arrangements that this does not remove all of our mental health provision from Ealing. It removes, it makes permanent the suspension of those two wards that were suspended during COVID. and more than half of them, 18 of them, have been re-provided on the Lakeside site. We've got other mental health services in Ealing, including for older people, including the 3-borough crisis house that we commission with the Richmond Fellowship at Amadeus House. And I think I'd be very keen to ensure that they understand that they remain available to them. The other thing I think which Richard and his team will pick up is we need to make it clear that we have services available for individuals and how they can access them. There are a number of our services that are self-referral, which we can support. And if the panel and members of the individuals who are here wish to help us disseminate that information, we would very much take you up on that offer.
Follow up though, given that there is this misunderstanding, do you not accept that that's a damning indictment of what you're currently doing? That the people who need access to these services don't know what's out there at present, don't know how they can access it, feel like they can't present to it, and don't know what the direction of travel is. Because you very cogently explained that we can allay all of their fears virtually, right? But at the moment, these very people who need to know what is going to happen have a seemingly incorrect assumption of what you're planning to do.
Thank you, Councillor Crawford. I mean, I'm happy to accept that there is an indictment there of if there are individuals who don't understand how to access mental health services in Ealing, then that's something that our organisation needs to do better. And I'd welcome your support to understand the individuals. If they'd like to contact me or the teams, we can help them understand how to navigate. We're not perfect, and there are a lot of areas that we are trying to resolve to improve access to mental health services, including commissioning third sector partners, etc., to do provision in a different way.
I want to hear from some other voices rather than my own. Councillor Conte and then Dr. Taylor, and then I'll come to you, Eve. Yes.
I didn't really want to talk. I didn't mention it earlier because I didn't really want to talk about sort of outpatient services. But I sort of following on from what Councillor Crawford was saying is that it is that perception that mental health services, and I work in Hounslow, so it's still West London. I know it's slightly different teams than the ones that work in Ealing, but it is exceptionally difficult for patients, and actually I think talking from staff, to get feedback or to get any clear information from West London mental health. I have to say, it's often a battle. Patients have their initial assessment. They're then often left hanging for a long time, not knowing when their follow-up's going to be, when they get input from therapies, etc. We chase, we send emails, we never get replies, or after weeks and weeks. It is incredibly difficult. And I think that, when you're talking about the acute services that you offer and the front end of that, and I completely understand obviously the stuff that you're putting forward about the provision, etc. But it is that perception that further down, it's really hard. And if people are left like that, over time, that demand at the acute end is going to go up because people aren't getting the service they need. Or as a patient said to me a while ago, I've just given up. I'm not going to even bother trying to engage anymore. And that's something I hear very, very frequently. And a colleague of mine said to me a few weeks ago, often it feels like there isn't a mental health service, an outpatient mental health service that really exists anymore.
Councillor Crawford, can you turn off the microphone? Thank you.
As a councillor, at some time, I would love to, although I'm not on this committee, I would love the opportunity to speak on the subject. It's up to your discretion, Councillor Crawford.
Yeah, indeed. I've got other people indicating. So the normal way in which anyway, it doesn't matter.
If you found the time, Councillor.
Yeah, indeed. I've still got another item to finish. I'd like to have Dr. Hilton answer the question.
Thank you, and thank you, Councillor Conte. I suppose I'll speak. I'll change my hat for a second to that of a clinician working in liaison psychiatry services. So I work when I'm having clinical sessions in the emergency department at West Middlesex Hospital, and in that context, it's fair to say that I recognise some of the concerns that you're describing around the planned care arrangements that we have. I also recognise cases where the outpatient care that's been provided has been very robust and has been adequate. So, and I guess one of the challenges that I have putting my managerial hat back on is that it's not a consistent provision currently. So I'm not going to pretend that the outpatient services don't have a lot of further work to do. You'll be aware that the Trust has been implementing a national program called the Community Mental Health Framework for Adults and Older Adults, which seeks to improve communication with GPs, to wrap care around integrated teams with primary care networks, and to be both more accessible and responsive, etc. Clearly, there is a lot more work to do before that aspiration is fully embedded. And I get both positive and negative feedback about mental health services, and the descriptions that you're describing is consistent with some of the negative feedback that I get. I recognize the challenge that we need to be able to have good planned care in order to prevent unplanned care, mirroring the arrangements that you'll hear from the acute trusts. But what I would say is I think this starts to stray slightly from the scope of the proposals that we're putting forward at the moment, because there is ongoing work to improve and make more resilient our community services in our community and recovery mental health division, as it were, and this is about trying to address the quality concerns that I'm also faced in the premises that we have in Ealing Hospital.
Thank you. I would just say this is the first opportunity for the panel to discuss these proposals. So the purview of this panel is exactly what we decide it to be. You know, it's not for you to limit the scope of our discussion. Dr. Taylor.
I just want to add, Chris, I certainly do welcome the Trust's increased provision in the step-down beds in Ealing. But I think the Trust needs to look at that even further, particularly in relation to ensuring that those Ealing residents that are in an acute psychiatric bed can come back to the borough as soon as possible in terms of continue that rehabilitation in a step-down bed in the borough that they reside.
It's about that retaining that local link to these services, because we all want people to rehabilitate and be able to live their active lives in their. No one's going to resile from the sentiment that Dr. Taylor's opined on there. It's just about how we get to that goal eventually. Right, Eve, I've given you an option of at least two questions.
Actually, I do need to make a comment. I think one of my problems with this engagement is it doesn't feel completely transparent. And I'm going to go to the next consultation meeting, so I look forward to meeting some of you. One of the things that's not made absolutely crystal clear is that we will have none acute mental health beds for people under 65 in Ealing. And you can dress up all the number of other beds that there are, and there are step-down beds, and there are acute beds for older people, but there are 0 acute beds for people under 65 in Ealing, but there are in Hounslow and in Hammersmith. And I'm pleased for people in Hammersmith and Hounslow, but it feels like an attack on this community. And whatever way you look at it, that's how it feels. We don't even get to use all the money that's released from closing Hope and Horizon wards within Ealing, only a small percentage. So it feels, and actually it really feels like, you know, a bit of a lack of interest in this area. And I appreciate there are community services and all the rest of it. And I also appreciate that you are under a lot of pressures. I would much rather you put your hands up and said, there's a mental health crisis. Let's all work together to try to resolve that. But that's never what we hear. So I just want to kind of make those feelings quite strong. And we've been out on the street talking to local people in Greenford and Southall and Ealing. We set up a petition when the beds were temporarily closed. We haven't presented it yet, but we will want to present it to you as part of this. And we have literally spoken to hundreds of people. And the one issue that is always coming up on the streets when we're talking about the NHS is always mental health. every solitary time people talk to us, we've spoken to so many families about the situation that they're in, and it's the one issue, and they do say they have difficulty in accessing services, and when they get the care they don't complain about it, but they have difficulties. And the fact that there are no acute beds in Ealing has made a lot of difference to some people's life who aren't accessing those services at all. So I think you might need to be sort of aware of it. My question, my very first question was actually going to be about the statement that you've made that you're satisfied about that there are sufficient number of beds, and other councillors have sort of addressed that as well. But back in 2020, when you last revealed the figures, you said it was 550 people from Ealing were accessing services. And even then, 350 of those, there weren't even enough beds in Ealing then. And that's why so many people were going to Hammersmith and Hounslow. And it's like, it's not going to stay still. There are going to be tens of thousands of people moving into this borough in the next few years because of all the developments, tens of thousands. So I just don't see how you can say that means that it's all safe and it's all going to be absolutely fine. So really, that was my sort of first question. So I think in all fairness, I ought to stop there and let you answer that. And then I have another question to follow up on.
So what I'll do, I'll let Chris and his colleagues come back on that point. We'll take your second question, and then we'll move to, I think, a discussion about how we can add value to the engagement that's already ongoing, because otherwise we're just going to go round in circles here. Chris.
Thanks, and thanks, Eve, for your comment. I think I want to be completely transparent with you about this. This will leave no acute adult beds for individuals aged between 18 and 65 in Ealing, but the Trust's view is that there will still be the availability of beds of that nature for people from Ealing. Now, I know that and I'm not trying to be to rely too much on semantics, but that is exactly what this proposal is describing, and it's about making sure that there are beds available in accommodation that's fit for purpose for individuals from Ealing when those beds are available. So the comment about reinvestment in the borough, it's reinvestment in acute mental health services that are available for individuals from the borough. And I'm happy to describe that, but you're absolutely right. This will leave no beds of that nature in the borough, but it's our view that those beds will still be available for Ealing residents when they need them. And I take your point about growth, and I guess what I'll need, I'm not going to repeat the answers I've given already, but I suggest that we will go back to look at some of the modelling that we've done, and we'll certainly make sure that that's made available to you and others that will benefit from seeing it.
And Eve, you had a second question. Oh, I can't take
No, answer them all anyway. Actually, my other question, which I'm not sure has been asked, but might have been asked somewhere else, I mean, I did mention about the money, is that within the wing, if you like, in that whole wing that Wolsey is, and I wouldn't dispute that Open Horizon probably aren't fit for purpose. But the fact is, what I'm not convinced about, that enough time and effort has been put in to look at what can be done. So, for example, we do know that within, if you like, the same area, we're separated only by a wall, is the Tony Hollis wing, and the Tony Hollis wing is a specialist forensic unit. And that was in exactly the same shape as a Wolsey ward, but investment took in, I think, about 6.5 million. And it turned it into, it's not ideal. And I know ideally in the future, there'll be a new unit, but that doesn't seem to have really been taken on board. I mean, given the need for beds, we believe, in this area, we think a lot more effort should have been put into actually looking at and finding ways to upgrade Hope and Horizon, if there is absolutely nowhere else, to make it at least, fit for purpose, perhaps on a temporary basis until maybe in the crystal clear future, there is a new provision. And there was a decent, actually modern unit, which was John Connolly, which was pulled down. And we still don't understand why that took place. So that's just really another point I just wanted to ask a question on.
I'm very happy to answer both of those questions, some of which is well before my time, but I'll do the best to share my understanding of what the decision making was. So you're absolutely right. We used to have the John Connolly wing on the St Bernard's site, and back I was looking back through old papers and saw that the chief executive before the current chief executive had presented to this panel more than a decade ago about some of the site master planning that we have for the St Bernard site, which presented a number of long-term plans, but it included the options around the replacement of the John Connolly wing on a temporary basis with those beds in the Wolsey wing, and some other moves, including moving the PICU to Charing Cross. But the reason that the John Connolly wing, as I understand it, no longer exists is that was the site that was chosen for the £60 million new facility that's been built immediately behind Ealing Hospital, which is a specialist facility for forensic patients. But that's I think all in the public domain, and it was attracting new capital investment for those specialist services that the trust has elsewhere in its portfolio. The second question then is about the facilities available for Ealing residents, and at the time refurbishment was done of the Wolsey wing. I think what we have learned in the years that have followed is that even with considerable investment in the Wolsey wing, the facilities remain unsuitable for the type of patients and the volume of throughput that an acute adult mental health ward has. I completely acknowledge there is still a low secure facility in an adjacent block of the old Victorian asylum. We as an organisation have separated out our decision making in respect of the specialist services from the local services, and it's certainly also the case that we would consider the Tony Hillis wing provision to be not fit for purpose. I think that's certainly the view of some of our specialist commissioners, and we have separate plans in place elsewhere in the organisation to see if we can re-provide accommodation in Ealing for that low secure facilities. But that's not in my division, so I'm not as close to the detail of that.
Right. There are a lot of comments, there are a lot of issues that have been raised by this. I'm going to try and see if we can plot a way forward together, because we're clearly not going to bridge the divergence this evening, unfortunately, and there's a lot of outside interest in these proposals, and I think it would be appropriate for us to look at convening some sort of forum whereby people can put more of their questions, even indeed introducing some additional public elements to the enhanced engagement consultation that is due to continue currently. So that is my first ask, is how wedded are we to the current timetable for enhanced engagement? How open are you to extending that engagement beyond the dates that have been indicated already?
So I think the most important thing for us is to ensure that we have spoken to the local communities and individuals that are affected in a way that is adequate. So I think there is a degree of flexibility and openness to make sure that we've done the best that we can with your support to do that. So there is some flexibility, and we are open to that.
So forgive me for a direct question then in response to that. How do you believe it is adequate? It has been adequate so far?
If I may, Chair, I certainly one of the things that you've indicated, and that some of the other members of the panel have suggested, is that the indication that from your perspective, collectively, it hasn't been. That's something that we'll be reviewing at the midpoint in the next few days, and I haven't yet seen the full feedback of what's been collated to date, but that may reinforce that view. So we have a further period already planned. It is possible to be flexible with the planned end date. So I would defer to seeing what I see when we have the midpoint review in the next few days.
Right, so if I'm emboldened enough to make a recommendation this evening, that we as panel would ask you formally to consider extending that engagement, both in terms of the end dates, and also the form of which that engagement takes place, I would hope that would be viewed favourably. Yeah, and I do have the reference in conclusion to this item the concern and disquiet of the neighbouring boroughs with regard to these proposals. I know that you've committed to and you've been to the Hammersmith and Fulham Scrutiny Committee, and you're planning to go to Hounslow if you haven't already been, and hold further engagement. But they are concerned that they haven't been adequately. I am going to use the term consulted, even though that gets us into some degree of difficulty on the legal position. Given that this is a proposal that will impact 3 neighbouring boroughs, we want to make sure that everybody has the ability to feed into this process. And the most important part of that is that locally elected representatives have the ability to put forward the views of their constituents. It's similar, in a similar vein to my previous question, we would like to revisit that level of engagement and work with you to design something that is more appropriately geared towards hearing from all the diverse voices, not just in Ealing, but across the 3 boroughs. Is that a conversation you're open to having as well?
It absolutely is, Chair. It's a conversation that we're open to having with you, and look forward to that conversation. As you're aware, after the Joint Health Scrutiny Committee for North West London, there was a suggestion that we should come together to brief the chairs of the 3 scrutiny committees for the 3 boroughs, and that remains something that I'm keen for us to do.
Just on that, we're waiting for your response at present in terms of when you'd be available to have that discussion, and we'd welcome that. And then finally, there is this point about how we measure success and what the return for Ealing residents is, because in the measurement of what is now a tri-borough arrangement, or will become a tri-borough arrangement under the implementation of these proposals, it's very difficult for us as a scrutiny committee solely concerned with the London Borough of Ealing to measure how much value for money and how much percentage-wise of the service Ealing residents or people who originally hail from Ealing or work in Ealing get as a result of something that is now spread across 3 boroughs. I understand that you've been doing it already, but it creates a statistical problem for us, because we're very defined by a local boundary that mental health does not respect, right? So how can we be certain that the money that flows out of Ealing's coffers as a local authority is invested for Ealing's residents in a situation where the provision is not going to remain within Ealing's borough boundary?
I recognise the question that you're posing, and I also recognise that it's a question that's posed by some of the neighbouring boroughs as well, about the impact of their investment for their residents if Ealing residents are admitted in their geography. I would be very committed to working with the 3 councils to identify ways of measuring and benchmarking this in any way we can. There are some ideas that we have, and we have some data that is available to us cut by residents, which may help us with that conversation, but we're very happy to commit to that.
So I think the end point for this is that myself and Councillor Steed will summarise the discussion that we've had here, and together with Anne-Marie and colleagues, we'll write to you formally to put those requests in writing that I've just made to you. And then we'll work on, with a view to taking a progress report, either on the enhanced engagement as it still stands, or something that is more like a progress report on your proposals with some metrics for success at a future meeting of this panel. Is that okay? Yeah, brilliant. Okay, well, thank you very much for your time and your forbearance. And I need to apologise to Nehar and Vijay that we're significantly delayed in getting to what remains a very important item on primary care and GP services, because colleagues have been asking for this item for some time, and Nehar and Vijay have given up their time this evening and sat here patiently waiting for us to get to this point in the agenda. I'm sorry.
Thank you. Can I just check how long we have on the rest of this meeting for this item?
We've blown through all the deadlines. You have for as long. Look, take as long as you feel is necessary to present, and colleagues have questions. And I'm committed, even if it's going to upset some people, to stay here for as long as we need to have that discussion. Okay.
Thank you. Okay, I am going to try and give a summary. There are lots of slides here that you have been provided with.
I'll tell you what, well, it's a dangerous assumption, but I'm assured by my colleagues that they've read the entirety of your presentation. So if you want to draw out the highlights, I know that colleagues have some questions, and we'll go from there. But take as long as you feel you want to. Yeah. Thank you. So I have got the slides up here, and I will go through a few of them. But Dr. Taylor will step in as well as when we come to some of the slides. I would summarize what I'm going to say in this pack, however, with 6 points. The first one is that the demand, as we all know, has increased post-pandemic. That is, everybody knows that, everybody has seen that, and that's very widely acknowledged. The capacity has tried to increase as well, and it has increased, but it's been difficult for our practices to stay on top of the sheer demand that's coming through. And therefore, the way that the practices are delivering care has changed. The third point is quality is still an important focus, and being more proactive in supporting our residents and once our practices have identified an individual with a certain condition, following up them and optimizing their care is a critical part of what GPs should be doing. The fourth point is that as a result, a number of initiatives have been launched nationally, but also locally, to try and support our practices to be able to manage that demand. The fifth point is that those methodologies include improvements in use of technology, but also workforce initiatives and supporting our practices with recruiting and retaining their staff, which are both nationally led and locally. And then the last point is about the future of care and having a resilient primary care service for the future as the population continues to grow and demand continues to grow. I'm not going to go through all of the slides. I'm just going to give a couple of points from a few slides as a reminder to members on this scrutiny panel. So just as a reminder, there are 71 practices in Ealing. It is the largest number of practices within Northwest London, and it is, I think, the third largest from a number of practices in London as well. So we have got a very large population to serve as well, and registered patients is what the GP practice and health services are responsible for delivering the care for, not just the residents within the borough. And they have organised themselves to work as primary care networks, and that's really important for the future of delivery of care. And some of these slides just give you a bit of information. A couple of key things around workforce, and I'll let Vijay come in here in a moment, is that the number of GPs we have is around 232 based on our data, but not all of them work full-time, and others would be doing other roles as well. And we have a number of nurses as well, but we have a number of other workforce that have been brought in over the last few years to try and support general practice to be able to cope. And they include pharmacists working within the GP practice, physicians associates, even paramedics and social prescribers, as well as mental health workers. I'll let Vijay come in here.
Yeah, I just wanted to spend a little bit of time talking about the GP workforce. And as we know nationally, that, you know, time and time again, it's been quoted that we are actually facing a GP workforce crisis. And Ealing is not unique in that situation. As you know, the government promised 6,000 new extra GPs. That hasn't happened up until now. And if you look in the slides, you'll see that in terms of the whole time equivalent GPs per thousand, in Ealing, we are our Ealing average is less than a North West London average, not just for GPs, but also for nurses. And what we're seeing is that the new GP workforce generation that's coming through the training, a certain portion of those really are looking at much more of a portfolio career rather than really bedding down into primary care. They're looking at working either as sessional GPs, looking at other avenues of work, and that is actually having a negative impact in the GP workforce. And in Ealing, our percentage of sessional GPs is above 55%. So, we do particularly have an issue in Ealing around the workforce. And then we've got the issue around the retirement bubble. So we have a quite significant proportion of our GP workforce over the age of 60, and hence over the next 5 years to 10 years, we are going to further fuel that workforce crisis unless we try and do something about it. There has been significant improvements in terms of expanding the primary care workforce, particularly in relation to our additional roles. And obviously this slide describes the various additional roles that our PCNs have been actively recruiting over the last few years to ensure that the services that we offer in general practice and primary care does fulfill the needs of the population that we serve. And we have expanded on that in terms of our new roles, particularly in relation to community pharmacists, paramedics, first contact physios, our social prescribers, and they have played a crucial role. But we do know that often the public's perception is that the person that they want to get their needs met is their GP. And so we do need to try and shift that cultural change, that not only the GP that fulfills the needs of the population, it's also the extended workforce. So what are we trying to do about that? So there are a number of national schemes looking at how we can try and improve and bolster the primary care workforce, particularly in relation to the reimbursement schemes that are available, our GP retention schemes in terms of getting GPs that have had a break from practicing coming back into general practice, the mentoring scheme. We've got our SPIN fellowships in terms of our new GPs that come on board. And then locally, we have set up a workforce task force. And I sit on that to really look at what we can do locally to try and encourage GPs to work in Ealing. And we have, in fact, increased the number of training practices in Ealing and hence the number of trainees. What we're trying to do now is to actually ensure that those trainees, that once they come out of their training program, actually stay and work in Ealing. And that's really the crucial part of it. And a lot of that part of that does stem to the fact that the significant pressures that general practice face, the workload and stress is now dictating what careers pathway our new generation of GPs are undertaking going forward. Health Education England have been looking at how we can try and improve the professional development and retention of GPs, and some investment has been put at a PCN level to develop GP and nurse educators to support our workforce in terms of fulfilling their continual professional development and really trying to support them to continue to practice at the top of their license. We've also started to look at how we can improve our nurse workforce, and I'm particularly concerned about our nurse force, particularly in terms of the level we have in Ealing, but also there are a significant proportion of our nursing workforce above the age of 60 in Ealing. We have got one of the highest in North West London. So in terms of having that apprenticeship nursing associates training is going to be key in terms of getting and training new practice nurses in general practice. And as we know, they have a crucial role in terms of not only immunisation and preventative medicine, but our chronic long-term disease management is primarily managed by our nurses in Ealing.
Do you want to?
Yeah.
So thank you. So the next section I was just going to talk about, actually just one additional piece of news. We've been joining the Ealing Jobs Fair and today was the second one, really successful, and some of the non-clinical roles we have a stand. And at the last one, we actually had 8 positions from 6 practices and 4 people of local people took up some of those roles. So it's really good, and we're going to continue to do a lot more of that, working across the partnership. So the next section I was just going to quickly talk about, and I know this has been of particular interest to this committee, is around the Ealing standard. This was a contract that was put together, a wraparound contract that was developed back in 2017 when it went live. The success of it has showed, it has allowed our practices to continue to invest in the workforce, also, although there is a crisis that we can absolutely see. But you can see from the next slide that I will just put up now, is that some of the performance rates of some of the indicators that we've been measuring are pretty good in Ealing compared to Northwest London, and they will continue to improve over the year, but there will be some indicators where there's more focus is absolutely needed, and it's varies year on year. The number of people that we now have, for example, right from the very outset, when we first set up the contract for diabetes, the number of people that had a high risk of developing diabetes weren't registered with GPs practices, or practices didn't know who they were. Through this work, they now know, and we've got thousands of people who are now identified as having potential for developing diabetes, and then more proactive care to support them. And same with a number of the other support contracts that, specifications that are within the contract, like learning disability health checks. We continue to try and improve the number of people with learning disabilities, ensuring they have action plans and health checks. But absolutely, when the COVID pandemic hit, our GPs had to step in and run the vaccination centres, the COVID hubs, testing, and they were flexible and did whatever they could to be able to deliver some of the demands that the pandemic needed. And as a result, some of the indicators within the standard will have dropped during that time. So getting back on track on some of those is really critical. And I think the really good news is that actually everybody's been looking at what we've been doing in Ealing over the last few years and is saying, actually, we want to try and do something similar. We need similar set of standards for the whole of Northwest London, and there's lots of discussions happening about how we extend a contract or something like that going forward. The next quick section, which I'm just going to go through, is around some of our feedback from our residents. So, and you heard already that some of the feedback is around mental health, but definitely when we're out doing engagement work with our local residents out in various places, inevitably we hear about it's really tough to access our GP practices, and I can't get an appointment on the same day, or other things. And I think it is really important that all of this information is seen in the round, and it's not just the access. And I think the demands and the pressures need to be seen as well, and all of the work that we're trying to do to then address that as well. And that's where the support of this panel is really critical, and all the councillors in trying to get that message out there about different ways that residents can support themselves by accessing community pharmacies or other routes. But when they do need to get access to a GP practice, we're trying to do everything we can to work with our practices to try and improve that access. And some of that includes improving telephone systems, and a lot of residents have described the difficulty in getting through on the telephone, getting an appointment on the same day. We are investing in a number of practices to upgrade their telephone systems, and that's in process. That's to move to cloud-based telephony systems, which allow more lines to come in rather than just waiting on a line at the end of a queue and then dropping off. So that's work in progress, along with other things. And there are a number of residents who have used the online consultation type tools and have found that really valuable. Understand that it's not for everybody, but the GP practices are open, and patients should be able to go there and contact practices by telephone as well. And we use the patient survey data that is run by Ipsos Mori, but also Healthwatch, that does a number of surveys right the way through the year in a number of practices. And we use a lot of that data, presenting that back to our practices and working with them to try and help them to develop action plans. But this is where it's really important that everybody understands the different sources of support that are there for our residents who need general practice. There is definitely room for improvement, and some of these slides on patient survey data demonstrate the level of variation. These are primary care networks across Northwest London, and you can see the ones in purple are the Ealing ones, and you can see that there is the variation for the number. We looked at 3 questions in particular, and one was how easy was it to get through to someone on the phone. The next one was did they have a good experience of making an appointment? And the third one was how satisfied were they with the appointment times available? And a couple of years ago, and we did bring it back to this committee and our Health and Wellbeing Board, I believe, last year, was Healthwatch did a longitudinal survey comparing Ealing to Hammersmith and Fulham and Hounslow. And some of the indicators were better in Ealing and some of them were worse. And it's definitely information that we needed to take on board, and therefore some of the actions that have followed as a result. Just going to do a couple more things. It's in the next section here, we've got data around access, and there are key requirements in the core general practice specification, but there are also things that we have put in our Ealing standard about the expectations around access and what we would want our practices to be able to offer to our residents. What is very clear from the data is back in 2018, you could see the number of appointments per month, whereas around 155,000 appointments. In October, we measured 212,000 appointments. So you can see the increase in demand that has happened. So being able to keep on top of that is really important. And DNAs have sort of, so DNAs is people that did not attend or they had a booked appointment have remained consistent. PJ?
Yeah, just want to talk about what we're going to be doing across Northwest London to really try and improve access into general practice. So myself and a team at Northwest London, a primary care team, are leading on a piece of work looking at access, and we are currently looking at developing an access specification right across Northwest London for every single practice in terms of getting some level of consistency with respect to how appointments are captured on the GP IT system, but also to ensure that in terms of registration of patients, that there is no barriers in terms of patient registration, particularly in relation to providing proof of ID or proof of address, etc. So, and what is going to be really important is in terms of using the GP survey as a way to have that continual dialogue and conversation with the PPGs within individual practice in terms of the experience of access and how they can develop an action plan to improve the experience of access into general practice. And I think what is important is the commitment that Northwest London are making, particularly in relation to telephony and cloud-based telephony, in terms of improving the telecommunication system that practice uses from the analog back to cloud-based, particularly in relation to giving practices a better understanding in terms of their call volume, the traffic, the peaks and troughs of when patients are calling, so that they can then respond in terms of ensuring they have enough receptionists to manage those calls, but also in terms of the call waiting times. And obviously, and we do know anecdotally patients do say that they often are waiting over an hour on the phone to speak to one of the receptionists, but we'll be able to now be able to have the data to look at that in terms of what we can do. And so that this investment and rollout in general practice is a huge level of investment to try and get to every practice to a sophisticated cloud-based technology. Estates.
Yeah, so I'm not going to go through.
I'm really sorry.
detail.
Is it possible that I can move it on to the questions, just in the interest of time? I appreciate you've got some things you want to share with us. If we don't cover them in questions, perhaps we can come back in the summing up. And I've been very naughty at this point and not introduced Dr. Audrey Silver, who's still with us online, I hope, even though we've kept her waiting for nearly 3 hours. And you know, she's not. No, I don't blame her, frankly. At this point, look, clearly we're not going to be able to give the time that we wanted to this item. So I think my first recommendation is that we set up something whereby at a convenient time we can ensure that councillors in general and I can collate some comments that can be fed through, because there are a lot of comments. I would have to say that this, when it was published, the number of comments on GP services almost exceeded the number of comments in my inbox on previous items. Not all negative, I must say. Look, I want to open it up to colleagues who've got questions. If they haven't got questions, I've got some. Yeah, I knew they'd have questions. Right, Councillor Conte and then Councillor Weston.
Thank you. Yeah, thank you for taking us through that. So a couple of questions. Firstly was just on access. I think there's obviously, as you said in the report, there's a really mixed level of access. And I think I know it's very difficult in terms of obviously meeting demands. I think one of the things is actually the barriers that are put up to get to access general practice. I was on the doorstep, this was a few months ago now, but I was speaking to a gentleman who, he's in his 80s, contacted general practice, and they said, we have to fill in an online form. They're like, that's the only way that you can get an appointment. I just thought that's crazy. This is a person, like for me, I try to get access to see my own GP, and they said, well, you have to fill an online form and we'll call you any time during the day. And I was like, well, I work. And they're like, that's the system. They called me once, I was at work. I called them back. They're like, well, you have to fill out the form again tomorrow. You missed the doctor's call. I was like, well, I work. What? And so I went through the same rigmarole again the following day. And I called up at lunchtime and said, well, I was working. I even put in the form, I don't have lunch between sort of 1 and 2 o'clock. Could you try and call me then? No. In the end, I sort of just gave up because I just thought, well, what's the point? How is that still the method at which some practices in Ealing operate to get it? I just think I work at a general practice. And if my practice were like that, I would be kicking up a fuss. It's crazy that that's a sort of, it may work for retired people. It may work for people who maybe aren't at work. But for people between 18 and 70 who are at work every day, that just doesn't work. And I just can't believe practice in Ealing still operate like that. Just my second point was just on allied health professionals. Obviously, they play a really important role. I just think there is, when it comes to managing long-term conditions, however, I think we just need to be really careful in terms of these are sometimes the most complex patients. And there's a reason why it takes 10 years from when you start medical school to end up being a fully qualified GP and the value that brings. And I do think sometimes there is a worry that actually that some of the things are, and I don't know what the right word to use, but are being, downgraded is not the word I'm trying to find, but I can't find the right adjectives to describe it, but that patients aren't necessarily, when it comes to long-term disease management, I don't necessarily think that sometimes always these allied health professionals can give the same value. And sometimes there is duplication if patients are speaking to a pharmacist and then to a nurse, and actually that makes the work a lot bigger. And I was speaking to a partner colleague in another practice a few weeks ago who was saying actually that what he's found is actually it's generated a lot more work because they then have to go back and maybe make adjustments and changes to what those allied health professionals have seen. So there's a clear role for them and they're incredibly valuable. But I do worry with some of their role in terms of long-term disease management.
Just picking on your first point. Yeah, yes, I absolutely agree that, you know, some of the experiences that individuals have with their individual practice, it has been very, very difficult. And I think this really stems back to when the COVID pandemic hit us, in terms of how general practice continued to deliver care to the population and to ensure, you know, that the safety of not only the patients but the workforce within primary care were protected. And we did go into that mode of working where it was primarily the default was same day access, reactive care, and that's what happened during the COVID pandemic, primarily in general practice. And that shift from that is taken longer than all of us had anticipated in terms of allowing our populations to have a much more planned approach in terms of how they book their appointments, when those appointments are booked, to particularly in relation to those people who are working, who find it very, very difficult to access general practice on a same day basis because of their own working lifestyle and their ability to then engage with the GP practice. And so we are making inroads in terms of trying to improve that ability for patients to pre-book appointments ahead so that they're able to then have a booked plan appointment at a specified time. Obviously, we need to balance that in relation to ensuring that doesn't then result in an increased level of DNAs, because that is one of the challenges around pre-booked appointments, but also to ensure we're able to do that and manage that equilibrium between that reactive and that proactive care. And that's the balance that we're trying to actually get to, because at the moment, we all know that a lot of primary care effort and workforce is being concentrated on that same day demand, and our planned care is now being sacrificed because of that. And we are trying to shift that in Ealing. And we're partly doing that by looking at our integrated neighbourhood teams, our NDT approach, particularly in relation to what you say in terms of individuals being able to work in the top of their license, but also to ensure that you have clinical oversight from a GP, particularly those patients with long-term conditions and complex care. With relation to digital ways of working, as you know, that was accelerated during the COVID pandemic. NHS England had always had within their program of delivery that digital movement in terms of GP access was always going to happen. When we hit the COVID pandemic, that was accelerated, and every practice had to then look at how we deliver primary care. And using online platforms was one scope that we had available for us. And again, right across Northwest London, we have every practice delivering online consultations, which in fact what it has done is actually increase the level of access into general practice compared to the traditional way that patients used to access us through telephone and walk-in at their GP surgery. Yes, there are barriers to it, and it's not for everyone. You're absolutely right. The patient that you described, the 80-year-old, clearly, that is not suitable. We would absolutely agree with that. And online consultation shouldn't be a barrier. It should facilitate access, not become. But it is. You're absolutely right. I'm not defending that kind of practice. I'm just saying that it does exist. We are, working with individual practices within the PCN to ensure that practices understand the needs of their population and have that blended approach of access. And I think that's really important going forward.
And I think that was fairly comprehensive, but I respect the fact that we're not diminishing any of those concerns, because we hear them too often. Councillor Weston.
I shall attempt to be quick, but there are many questions that I wanted to ask, so hopefully we will get an opportunity at another stage. But I would say thank you for the full report, actually, and I think it's quite a frank and open assessment of sort of where we're at. I'll focus on workforce. So for me, because I'm a details person, we talk about physician assistants. We've also got GP assistants and physician associates referenced. I assume we're talking about physician assistants that are regulated by the GMC rather than lots of different roles, but maybe you can clarify that point. And then I think for me, there's something in here about, so I know how many GPs we have and how many nurses we have, but I don't know where the gaps are in the vacancies, to be able to ascertain kind of the scale of the problem in Ealing. So it'd be helpful to get a sort of sense of that. And then of course there's the kind of pipeline in terms of how many nursing associates we're training. The numbers look pretty low from what we've described. Appreciate the role only came into force in 2019, but I just feel there's probably a bit more on the workforce that we need to kind of get to grips with.
I certainly agree with you in terms of we do need to drill down further, particularly in relation to the workforce, and it actually is quite difficult for us from a borough perspective to get an absolutely accurate picture in terms of the GP workforce, but particularly in terms of vacancies and the recruitment, because what we do find in general practice is that practices will try and fill the shortfall and the gap by using sessional GPs on an ad hoc basis, but that is not sustainable. And we all know when we look at the various WhatsApp groups that we have in Ealing from the GP practices on a daily basis, there are several hundreds of posts about we're looking for locums on a daily basis. So it is difficult to know exactly what that gap and shortfall is, but it's certainly something that we will take back. With respect to those other roles, for instance, a physician's associate or a physician assistant, they are the same thing. There is a unique training program for them, and we know that universities like Brunel, where they are going through this program, they're not currently GMC regulated, but there is discussions with the GMC for going forward. They will be. So certainly that, and most of these are postgraduates who then move on to that physician's associate training program. Clearly, when they do come out of that training program, they will continue to need mentoring and supervision by the GPs in the GP practice. So in terms of their independent ability to practice. So, but these are all opportunities and avenues to increase the primary care workforce. They're not there to replace GPs. They're there to support general practice and GPs and really be an adjunct to what we currently have. But you're absolutely right in terms of what we've presented here. It's very difficult to give you an exact picture as to where we are in Ealing, but it certainly does give you a snapshot of our current situation.
Mr. Cook was next.
Thank you, Chair. I'm rather concerned about the access and workload, because according to the data that you've provided with the number of patients registered with the PCNs, we're at 460,000. Now, the problem I have is, according to the census, the population of Ealing is 367,000. So in other words, we're picking up 93,000 from outside of the area. Surely that must have a massive influence on the way that you could get appointments and the workload that GPs and nurses are having to deal with in primary care?
Thank you. So it's a really important question, and it's a well-known issue, hence putting it in the pack and highlighting it as a really important issue. Some of it will be that patients have moved back home. So they've been here, living here, and then they've gone back home and they haven't re-registered somewhere else, and therefore they haven't come off the registration locally, but they haven't needed services. Some of it will be that residents live across the border and access services are registered with GPs in Ealing, and vice versa as well. I can't tell you why there is such a discrepancy. To be honest, we haven't been able to get to the bottom of it. The funding that we get is based on GP registrations, however. So we're working to modelling all of the workforce and access and capacity to the larger number, that's the GP registration figures.
Right, so I'm in a tough spot here because I said I wasn't going to go beyond 10 o'clock and we're about to break that rule. There's a lot of questions that my colleagues would like to ask. There's a lot of misinformation out there. I've referenced that one of the local press this morning helpfully splashed all over their websites the negative elements of this report on GP access, which was very helpful of them ahead of this meeting. I think what the best thing to do is for me and my colleagues to collate some of these questions, to send them through to you. You can provide some updates on that. And I do think we probably need to schedule in something probably in between these meetings that would be an opportunity for all councillors and co-optees and residents of Ealing to have a discussion similar to some of the discussions we had at the, I'm going to get the name of it wrong now, the Health and Neighbourly Care Forum that was hosted in the Victoria Hall a month ago, where Dr. Taylor and I went around various stands and spoke to various practitioners. My one takeaway from this document is about both the pressures that VJ and Neha have outlined, which is that we have a number of long-standing, much-loved GPs across the borough who are coming towards the end of their working lives. We've seen this very acutely, to be parochial for a moment, in my new ward of North Acton, where a couple of practices have a couple of practice managers and GPs have decided to retire, and at the moment we can't yet re-provide all of that service to an area that's already oversubscribed. But I am encouraged that, and I was sceptical, Neha will remember and Dr. Taylor will remember, I was very sceptical about the Ealing standard at its inception. And the Ealing standard has been terrific in driving up standards, not to diminish the concerns that Councillor Conti has raised very, very accurately about some of the issues. And I would like to, you both referenced the performance of GPs during the COVID pandemic and taking a leading role in the vaccination programme. I mean, that was exemplary. That was fantastic, and it continues to be in response to boosters and everything else going forward. So there's clearly some work to be done. I'm really interested in how we can get that community health offer working. We've got a well-established relationship with the local authority. I know, it's a theme throughout each of the presentations this evening. I think that there's still room for closer collaboration. And I'm actually interested in, given the amount of development that's going forward in the borough, and given that, some of the proposals that VJ has mentioned already in terms of the government training X, Y, and Z, there'll be other routes to securing funding through various pots of money that, if we come together to deliver, that can make a real tangible difference to local communities. So look, we want to work with you. I think Councillor Steed and I will need to take away the best forum for us to do that, so that we can provide some more information by the end of the municipal year. But it took an awful lot of time to gather the data and to measure even just that snapshot. And let's not be glib about what we've achieved here. We've got a comprehensive set of data about performance in our GP services that I can wave in the face of people who claim it to be much worse than it actually is. So that's an achievement. I would like to ask you to take away to your colleagues our gratitude for all the work that they do on a daily basis. We recognise that there's improvement to be made, and you do too. And I really appreciate you coming here to give that snapshot and your ongoing commitment to scrutiny of that work, and where we can be partners in that process. Do let us know how we can add value. Look, I really thank you for taking the time this evening to be part of that, to start that discussion, because I think it's important we keep it ongoing. So thank you very much. Thank you to everybody for their forbearance. I'm afraid these meetings are going to be like this until we get through the work program a little bit, but hopefully we've made some progress on some very challenging issues this evening. And I think I would appeal to colleagues, do write to me and Councillor Steed and Anna Marie to continue that conversation, and we will work up forums and ways to get those questions answered. Thank you very much. Thank you, everybody. Sorry? Oh, yes, I should have told you that the date of the next meeting is the 1st of February 2020.